With this, for our corporate presentation, I would like to hand over to our corporate GM Corporate Relations, Mr. Samir Deni. Over to you, Samir, sir.
Thanks, Komal. Good morning, all. Good morning, doctors. Thank you so much for your time on Sunday morning, Ganpati days. I can understand the Aarti, Mahalakshmi Day also here, this side, I think, in Nagpur. So thank you so much for all the doctors who are physically present here. And I think there are some 65, 70 doctors watching this virtually also. So welcome all the doctors. Speracon today is the first Speracon which we are organizing as such. And I think this is the best occasion or Shubha Muhurat, Ganpati days and Mahalakshmi today, Naman. Speracon is being organized for the first time in India, and we have plans going ahead in future also for Speracon, which is organized by Spera, which is one of the 8 divisions. Like we have total 8 marketing divisions into different specialties at Indoco, and Spera is a division into gynecology. So today, just briefly, I would like to take you across to Indoco because we know that our representatives, our team of managers keep visiting you, but then Indoco at a glance, it's a occasion where we can just brief you on the latest developments, and then I'm sure after knowing Indoco in a little more deep, you'll be also more confident or maybe proud or happy to be associated with company like Indoco. As you all know, doctors, India as a country, we are celebrating 75 years of excellence, or 75 years is the platinum jubilee, independent year which we are celebrating. And I feel happy or proud to share with you that Indoco at the same time is also celebrating its 75th year of existence or excellence. It was established in 1947, just 7 days after India got its independence. So it is a small, interesting story behind the foundation of Indoco. What is the corporate presentation? So we all know 15th August 1947 corporate presentation. Thank you. Page down here. Yeah, made in 1947. It's a small, interesting story behind this. On 15th August 1947, when India got independence, then that time the government actually banned importing and exporting of drugs because they wanted to encourage indigenous manufacturing. And before independence, Mr. Govind Ramnath Kare, who is our founder and founder of Indoco Remedies, he used to import drug from European countries and he used to distribute it to South India and Goa part. That time the name of his foundation was, or trading company was Indo-Continental Trading Company since 1945 up to 1947. But then after independence, the importing and exporting was banned. And suddenly there was a ban on a business, but instead of getting dejected, Mr. Kare saw an opportunity in this problem because he then saw that government is encouraging for own manufacturing. So next day, on 23rd August, he approached the government officials and registered the company. And earlier it was Indo-Continental Trading Company. He picked up 2 words, Indo and CO from Continental, put it together to form Indoco Remedies. So when problem comes in life, it comes with a bigger opportunity. So that way he worked on it, and then the company was established on 23rd August 1947. So along with India, Indoco is also celebrating its 75th year of excellence this year. This is our first manufacturing, or this is our first R&D or manufacturing plant in Thane that time. It was established in 1952 at that time. And then Mr. Sureshji Kare, he is our chairman. He took over the reins of Indoco at the highest level as chairman and managing director in 1963. I think this could be one of the record of its own kind that any person leading any organization for so long. So since 1963 till today, Mr. Suresh Ji Kare, basically a Goan entrepreneur. He's our managing director and chairman since last almost 58 years. I feel proud because my team has taken a lot of efforts here in organizing this the event, and this is our first batch of field force, the medical representative and managers in 1976 when we started our operations all India. Now, that time the size was just 10, 15 field force. Today, it is more than 3,500 field employees. Then in 1997, commercial production of Goa Plant 2, it is started. We have total 9 manufacturing facilities, which I'll just share with you in my next slide. And the top divisions as such, number 1 in dental segment is Warren, and in Ophthal, it is Warren Excel. So these are the top in their own therapeutic segment, all India number 1 divisions. Indoco got listed on National Stock Exchange in 2005. Then our new R&D center at Rabale, we started commenced in 2006. R&D is supposed to be a backbone of any pharmaceutical company. And we are one of the strongest R&D setups spread over an area of 1 lakh square feet, where 600 scientists, they work for us in the shifts day and night, and they work on the excellence, production excellence, and then quality assurance, and new drug delivery systems, and so on. Then Mr. Suresh Ji Kare hands over the management reins to Aditi Kare Panandikar. Aditi madam is our managing director, and she's heading Indoco she's associated with Indoco since last more than 30 years. She has taken her higher education from OES State University, USA. And Mr. Sandeep Bambolkar is our joint managing director. He is also associated with Indoco since last more than 35 years. And he takes care of finance, operations, and international business. We are present over more than 55 countries across the world. So proudly we can say it's an Indian multinational company, a global company. Recently in 2016, we crossed the sales turnover of 1,000. Today we are at 1,500 crores. So thanks, doctor, for your valuable support, and we keep growing. So request for your support for that. Indoco's Goa Plant 3, we have total 9 manufacturing facilities. Out of 3, there are 3 factories in Goa. Out of 3, the Goa Plant 3 factory is for tablet manufacturing. And this particular factory is approved by European country GMP certification. So whatever tablets are manufactured at Indoco are manufactured at Goa Plant 3. And happy to share with you that one of the products which we believe and prescribe is Methical is being manufactured in the same facility. So you can rest assured for the quality assurance, because whatever the EU GMP certification or the quality requirements are completed by Methical product. So the assurance of quality is there, and thank you for your support for this product. Then Clinical Research Organization, that is CRO, something which we have acquired from Nicholas, which was in 2019. Earlier it belonged to Nicholas, which we have acquired. Of late, in our fight towards COVID pandemic, Indoco was the first company to supply the European countries. The first batch of paracetamol was dispatched by Indoco, and it was given a good highlight across media in all India national media. And Indoco helps UK in its fight against COVID-19 by supplying paracetamol tablets. The first flight took off from India was Indoco's flight to the European countries with the medicines. These are the 9 manufacturing facilities which I just referred to. R&D center based in Rawale, New Mumbai, then CRO Hyderabad. Goa, we have 3 plants. In Baddi, Himachal Pradesh, we have total 3 plants. Waluj, Aurangabad, we have 1 plant which caters to the African countries. And Patalganga, we have 1 plant which is into APIs, active pharmaceutical manufacturing. Out of 9, doctor, I'm very happy to share with you that 6 are approved by US FDA. It is one of the feathers in any Indian companies as far as in the cap is concerned, because now of late, you must have read in the newspaper also, many big companies are struggling to retain US FDA approvals because of the stringent rules now which they have placed into picture. Earlier, they used to serve us a notice of maybe 1 month or maybe 20 days in advance. They used to serve a notice and then used to come for inspections. Nowadays, they just come in the morning, will bell your door, and they'll just barge in for the inspection. But we are always ready, and this is how off late. In fact, last month Goa Plant 2 and Goa Plant 3 being Plant 1 and Plant 2 being inspected by USFDA, and we successfully retained it. So assurance of quality, as always, we believe in. That is our vision also. So that is also ensured by Indoco. As far as the revenues are concerned, last year we have touched 1,217, and this year we are probably touching the sales figure or milestone figure of 1,500 crores. Currently, we are ranked 21st as far as IQVA and 29th as far as AVAX ranking is concerned. Considering there are some 5,000 big or small pharmaceutical companies in India, 21 or 29th is not bad. It's good. But then looking at the infrastructure and the R&D capabilities, which I just shared with you, we probably feel that we deserve little more ranking than other companies which are placed at least 10 ranks above us, because they do not have the kind of infrastructure which we have. But no complaints. I request for your valuable support so that Indoco can get its deserved ranking in the near future. We have a workforce of over 6,000 employees, and domestic contributes to 51% of the total revenues, whereas export comes to 40% contribution, and API, CRO, and analytical solutions contributes to 9%. So 9 manufacturing facilities, 6 for formulation, 3 for APIs approved by USFDA, and even R&D center is approved by USFDA, spread over an area of 1 lakh square feet. And clinical research organization is also, as I just shared with you. Domestic business, there are 9 specialized marketing divisions. We have presence across India, pan-India, and 51 products are ranking in the top 5 in its own therapeutic segment, like Febrex Plus or like Cyclopam. These are the products. They are ranking in number 1 in their own therapeutic segment. So likewise, we have 51 products in their own therapeutic segments ranking amongst top 5. So that shows the strong domestic presence of Indoco. But honestly speaking, doctor, I must confess that most of these products comes from acute division. And now going ahead, we want to focus on the chronic or subchronic segments where Spera division, it comes into chronic division, where specialties like gynecologists, like you all doctors, you are present. So we want to establish more products from chronic divisions going ahead. So my sincere request to help us so that we also keep sponsoring or maybe organizing such CMEs, and our people are motivated to organize such events going ahead also. Domestic number 1 dental division I just shared across, and then we cover like all India 310,000 doctors and 70 million prescription are generated annually. So thank you so much for your valuable support for that. These are the 9 specialty marketing divisions which we have for domestic business. And this particular event today is being organized, which is highlighted here by Komal Spera, one of the divisions into gynecology. So today's event is organized by Spera division out of these 9 specialized marketing divisions. These are the top brands. So only 2 brands from Spera division are featuring here, like MCBM 69 and Methical. So request your valuable support for these 2 brands and also other brands for Spera division. When it comes to the fight against COVID, we do participate in many social events, and we have created a basket of products to fight COVID. One set of product was for prevention, and one set of product was for the treatment, where Carval Plus, Rexidin SRS mouthwash, Poviclean Gargle, Zimun CD, and Naricover is the recent launch lozenges for sore throat. This comes into the prevention category. And for treatment, we had product Favipiravir, Fevindo, and ATM is azithromycin. When it comes to international business, we are present in 55 countries. So far, we have filed 106 process patents filed by us. And name the country, doctor, we have the regulatory approvals right from USFDA, UK, MHRA, South Africa, Australia, African countries. So all those approvals Indoco do have, and with the help of that, we cater to 55 countries. While we take care of our business successfully, we do not compromise our commitment towards the society. In fact, we believe that giving it back to the society. Our founder, Mr. Govind Ramnath Kare, त्यांचं एक फेमस वाक्य होतं की ज्या समाजात आपण राहून कमवतो त्या समाजाचं आपण उतराई किंवा त्या समाजाचे ऋण आपण परत कसे फेडावेत ही आपली प्रत्येकाची नैतिक जबाबदारी आहे. So with this principle, he is to call it in Marathi, giving it back to the society, which is the principle of our Indoco Spreading Happiness initiative of CSR. That is Sumati Sangopan. Sumati is Sadbuddhi and Sangopan is nurturing. So nurturing with good intentions. So we have actually determined, or we have decided few areas of the operations when it comes to the CSR activities like sanitization, education, infrastructure, especially school infrastructure, where we have targeted some schools for girls in the interiors where infrastructure is a problem, toilet blocks is a problem, which prevents girls going to the schools. So we have identified certain schools and their infrastructure, which we have actually helped them. Environment and health. These are the areas of operations for CSR initiatives. The CSR rule has come into picture now, but Indoco is into CSR since 1945. And we donated 1 crore to PM's Care Fund when it comes to the fight against COVID. Some pictures just for your reference. Entire Wadia Hospital pediatric ward is renovated by Indoco recently. Then enhancing vocational skills because we believe in the woman empowerment. Near Jalgaon, there is a place called Bahadurpur. So we have donated Bhagini Nivedita. They have a huge work, for 10,000 women. They have a plan of empowering them where challenges from, the nature are like पाऊस नाही आहे, दुष्काळ आहे, गेली 10 वर्ष 12 वर्ष पाऊसच पडलेला नाही, शेतकऱ्यांची आत्महत्या. तर तिकडे आम्ही डोनेशन दिलं आणि जवळपास 10,000 बायकांना त्या स्वयंरोजगारातून स्वतःच्या पायावरती उभं राहायला मदत करतायत. सो दीज आर सम इनिशिएटिव्स थ्रू आवर CSR इनिशिएटिव्स. वुमन्स डे, वी डू बिलीव्ह इन वुमन एम्पॉवरमेंट. आमच्या MD स्वतः आदिती कारे पाणंदीकर आहेत अँड शी इज सक्सेसफुली हँडलिंग ऑल द डिपार्टमेंट अक्रॉस. आणि वुमन्स डे किंवा ऑल अदर इनिशिएटिव्स आर सेलिब्रेटेड विथ दी हायेस्ट enthusiasm and priority. We are Indoco Remedies, Doctor. Indoco I stands for India at heart, then independence at heart, integrity at heart, innovation at heart. So I stands for that. And we are R because we discover them, we value them, we deliver them, and we make them truly dependable. So we ourselves call as Indoco Remedies, which is respectfully Indian at heart, but global in vision. Even after this pandemic, right from our Prime Minister, Mr. Modi, and everyone for that matter is appealing for vocal for local. So we are local company and we request very much, we are Indian at heart, but global in vision. So this is the 75th year of excellence for Indoco. I sincerely request, Doctor, for your valuable support to Indoco Remedies, because not only Indian, I'm not only just appealing because we are Indian, but I'm appealing to you on the merits of whatever I've just shared, the infrastructure, R&D capabilities, manufacturing plants, the approval which we have got. We have recognized by the well-known authorities also, and the products offered by us. And this particular event, Spera, is the first initiative which we have started, the first inaugural session of Speracon today in Nagpur during the auspicious Ganesh Utsav days. And going ahead, we have bigger plans in mind. So please sincerely request, please help us so that we are also motivated to organize going ahead, very interesting and bigger events going ahead. In fact, after 2 years, I'm feeling the warmth of the physical event as such, because last 2 years, everything is going virtual. So digital events and all. So I was so happy to fly down to Nagpur and organize this event physically. And God's grace, everything will come down to normal soon. The pandemic gets over and we organize more and more bigger events going ahead together. Thank you so much, Doctor. Thank you for your valuable support to Indoco and request for your support. Thank you so much. And over to you, please.
Good morning, everyone. Thank you to each and every one of you for being here with us today. I, Dr. Sanjana Senani, along with
Dr. Neha Punyani.
are very pleased to be able to welcome all of you. Before we get started, I would like to express my sincere appreciation to all of you who helped us to make the event come together to become a success. This is a long awaited virtual come physical CME. आप न आए तो सताती है खलिश सी इस दिल को आप न आए तो सताती है खलिश सी इस दिल को आप जो आ जाएं तो खलिश और जवां हो जाती है
It is indeed a very pleasant feeling to come out of the virtual world and gather here physically. So, today's program is sponsored by Indigo Spera Division. Our scientific chairman for the same is none other than Dr. Rajesh Modi, sir, gynecologist, endoscopic, and robotic surgeon. Lots of efforts were put in preparing for this day by sir and the entire Indigo team. So, without wasting any time, let's begin Speracon for the first session.
Our first session is a session of interesting talks. The chairperson for this session are Dr. Indrajit Murik sir, who is a senior obstetrician and gynecologist in Nagpur since 25 years. Dr. Varsha Dhavle ma'am, who is past president of IMA Nagpur and a state supervisory board member for PCPNDT. Dr. Rupashri Bhoyer ma'am, who has an experience of 25 years in the field of obstetrics, especially high risk and gynecology, and is a medical director at ACE Women's Hospital. We request all the chairpersons to please come to the dais. The first speaker for today is Dr. Ujjwala Deshmukh ma'am, who is a past president NOGS and past president Indian Menopause Society. She is a senior obstetrician and gynecologist in Nagpur since many years. The topic today is Wonder Drug in Modern Gynecology, Vitamin D.
It's not on. It's on. Okay. At the outset, I thank Indigo people and also Dr. Rajesh Modi for giving me this opportunity. आत्ताच आपण इंडिकोबद्दल ऐकलं आणि मला इथे एक दोन ओळी म्हणाव्याशा वाटतात. येस, इंडियन ॲट हार्ट बट ग्लोबल ॲट व्हिजन. स्वातंत्र्य शुभ्रतेचा रंग इंडुकोला ठाण्याला विराजमान. स्वातंत्र्य शुभ्रतेचा रंग इंडुकोला ठाण्याला विराजमान. भाग्याच्या औषधी लहरीने इंडुको झाले रूपवान. थँक्यू इंडुको. Thank you, Chairman, for giving me this opportunity. Now, I will, without any wasting time, the dignitaries on the dais, nobody is there, but in the audience, my senior colleagues and also the senior teachers. Today is an auspicious day of Ganesh Pujan and Mahalakshmi Pujan. And as a Mahalakshmi, I always expect that all the girls should be taught about the bone health and the role of vitamin D in school health. And I hope that Indigo will help NOGS, NARCHI and our association to help in the school health program. So I expect that they are already doing that program. And in what is said nowadays, whatever been deposited in young age is then extracted. So if you have a good bone health in a school-going girls, then the chances of osteoporosis and the fractures will be less in the menopausal age group. So I expect these things from the Indigo. Okay? So before wasting our time, I will say vitamin D is a nutrient for every cell of the body. You can see that if there is deficiency, the brain is also neuronal level, it is affected. It is essential for the lung activity. If the retrospective studies are seen in the breast cancer, vitamin D deficiency is being observed by the surgeons, then the grip strength, we know the vitamin D since undergraduate that it is required for the bone health. That's all. But nowadays, since 2000 and 2011, the studies are going on and we can find out where and how the vitamin D works. Bone health, we know all. Then the allergies. It also helps in building the immunity. Skin diseases. So everywhere it works. Then prostatic cancer, if the vitamin D levels are corrected, slow growing prostatic cancer patients which are not operable, they improve a lot. So this is a simple thing which I want to highlight, that vitamin D is not essential only for infertility but throughout the body. So what are the sources? Yes, we know. Especially the non-vegetarian diet contain high levels of vitamin. And there are some fortified foods which are available. Most common, the available is the sunlight. But you know, it is between 11 o'clock to 4 o'clock, we have maximum ultraviolet rays available. And we can have daily rise of 10,000 units. But still we are getting so much of vitamin D deficiency patients. So mainly through the sunlight. Dietary sources are predominantly non-vegetarian sources. Only vegetarian source is the sun-exposed mushrooms. Vitamin D fortified foods are also available, and key role is the calcium metabolism in every cell, not only the bone. Vitamin D levels, according to the endocrinology, if it is less than 20, it is said to be deficiency. Oh, excuse me. Yeah. And between 20 to 30, it is insufficiency, and greater than 30 is adequate. And if it is more than 100, then it is a toxicity, according to the endocrinology. We know that classical effect is on the calcium homeostasis. And here, vitamin D has a role in the fertility. How? It has an effect on the placenta, in reproductive system, ovary, that it improves the stereogenesis of the sex hormones and folliculogenesis. In short, it also helps in the endometrium, increase by immunomodulation and also by the increase in the progesterone levels and the endometrium secretion and decidual. So it is important for the implantation of the blastocyst. It has also effect on the pituitary glands. If the vitamin D levels are low, then the FSH sensitivity is less. So in the field of infertility, it has an effect on the pituitary gland also. In the testes, in males also, if the vitamin D levels are low, the spermatogenesis and the quality of the sperm is also disturbed. So let us see vitamin D and follicular development. I just highlighted the first slide was accordingly. So in detail, vitamin D allows follicles to reach the terminal maturation. So it is important for the folliculogenesis. Vitamin D maintains luteal phase. Vitamin D positively correlated with the AMH. Anti-Mullerian hormone, it improves the sensitivity of the anti-Mullerian hormones. So vitamin D and PCOS, very commonly, all the infertilologists, they may be doing more than 40% of the patients, maybe girls, and also for the after marriage coming to the infertilologists for the pregnancy, 40% of the women are having PCOS. And vitamin deficiency is only dependent cause many a times. How it works? Let us see. Vitamin D deficiency increase, there is effect on the insulin sensitivity, increase insulin resistance, then it also causes the obesity, then decrease SHBG level because the sex hormone binding globulin is low, the free androgens are high and patients come with the hirsutism and acne. Then they have the androgen action. So this is the way how the vitamin D helps. If the vitamin D is corrected, only vitamin D correction can improve the insulin resistance and also the hyperandrogenism. So recent studies have shown, these studies are from 2011. Some literatures are there. Vitamin deficiency, there is effect on the parathyroid hormone, obesity, insulin receptor, insulin resistance, then insulin secretion is also low, and 125 hydroxy cholecalciferol in inflammation. If there is deficiency, it can cause inflammation. So unovulatory, ultimately it will cause unovulatory infertility. Calcium dysregulation, development of follicular arrest, and the testosterone levels are high. So overall, only vitamin deficiency can cause difficulty in conception and having good pregnancy. This is again one study which can show you how it helps in the in vitro fertilization in your techniques. The group 1, when there was deficiency, see the implantation rate is 8.5%. Or in group where the vitamin D levels were normal, the rate of implantation is 49. And in group 3, 49%. This simply, if you go through, this study of population is 300 women with PCOS and infertility going under treatment. So to summarize, that much higher rate of implantation and clinical pregnancy were observed among the vitamin D deficiency patient who had received vitamin D supplements and 25 hydroxycholecalciferol levels returned to normal compared to patients in which 25 hydroxycholecalciferol levels did not return to normal. This is a very positive study with the role of vitamin D. Vitamin D has also role in the endometriosis. Now all the gynecologists may be coming across that the girl, even at the age of 14, 15, came with a severe pain in abdomen. And at that time, Sandeep Nikhade or all the laparoscopic surgeon, even Fidvi sir, we cannot go for the laparoscopy to find out whether it is there is endometriosis, all that. And we find that she may be having endometriosis. And if the drugs related to the endometriosis, I will not mention the name of the drugs, you all know. If such drugs are given, and I have seen the girl coming to me, her vitamin D level was 7 milligram. And I corrected it and she relieved of the menstrual problem. So it is very common, not only for the infertility, even the PCOS girls coming to our OPDs are deficient of vitamin D. And so the endometrium implantation, decidual reaction, vitamin D is required, and for proper implantation also vitamin D is necessary. Vitamin D and in vitro fertilization. High levels of vitamin D in follicular fluid are associated with better IVF outcome. These are the studies done in 2011. Vitamin D causes significant increase in the SRG levels, so counteracting the advances of collagen. So overall is, if the vitamin D levels are high in follicular fluid, the IVF results are better. This is again one study. Women with sufficient levels of vitamin D are significantly more likely to achieve clinical pregnancy following the IVF. Clinical pregnancy rate after the treatment of vitamin D is going from 34.7% to 52.5%. Clinical pregnancy rate per embryo transfer is from 37% to it goes to 54.7%. So definitely there is a high income pregnancy rate and also the pregnancy outcome if the vitamin D supplementation could provide an easy and cost-effective way for improvement of the pregnancy rate. Coming to the male, yes, if you go, I have seen the people, we always feel that the women are, but I think we should go for the male investigations also, coming to your place. The levels of vitamin D in males, the androgen status, low vitamin D associated with the secondary and the compensated hypogonadism. Concurrent seasonal variation of the testosterone is also seen. Semen parameters, if we see, increased progressive sperm motility via VDR-mediated calcium release induces acrosome reaction. So this is how vitamin D helps for the spermatogenesis and good quality of the sperms in the male. Vitamin D supplementation. Yes, very easy. It's an adjunctive agent and it is available orally, relatively safe and cheap. It is also available in injectable forms. The endocrine practice guidelines are between 18 to 70 years, we daily requirement is 1500 to 2000 IU. If 2000 IU daily is given, there is no toxicity seen of vitamin D. Toxicity is not seen. So upper limit is 10,000 IU. 1000 IU daily increases the vitamin level by 10 nanogram. Vitamin D intoxication resulting in hypercalcemia, renal damage and calcification was not observed until the vitamin D levels are 150 milligram per ml. So it is relatively safe. So what are the treatment options available for us? Weekly, we can give 60,000 IU doses of vitamin D for 8 weeks, and followed by maintenance therapy, 60,000 IU per month or 1500 to 2000 IU per day. Second option is continuous monthly therapy of 60,000 to 1 lakh IU per month. It is 1 lakh injectable is also available in the market. Third option is daily continuous therapy of 1000 to 2000 IU per day. And fourth option is parenteral megadose, that is 3 lakhs to 6 lakhs. When there is a deficiency and we are not sure whether patient will go for daily, we can give injectable. So to summarize, vitamin D has association with fertility. It has been proved. Single vitamin D can improve PCOS and insulin resistance. Vitamin D assists in production of AMH, antimullerian hormone, and improve egg quality, enhance ovulation, so that thereby increasing the chances of conception. Increase FSH sensitivity, increase progesterone production, improve pregnancy outcome, improve sperm quality and production in the male. So in the way pregnancy outcomes means the abortions, preterm deliveries, incidence of PIH, this has been reduced if the vitamin D levels are maintained. So the carry home message from my side will be every couple seeking for fertility should be screened for vitamin D level. Thank you for patient hearing.
Thank you, Ujwala Deshmukh Madam, for a very informative lecture. I would like to add that all obese women planning to conceive should be started with vitamin D along with folic acid. And any questions from the audience? No questions? Thank you, ma'am. Thank you very much.
Thank you, ma'am. It was a very good and informative talk.
Thank you, sir.
And the take-home message was very good that you should screen vitamin D levels for all the patients. Preferably, though injectable may work better, and oral bolus also is what we prefer, but the daily dose which we give is much better absorbed and has much better results.
And also, it looks like it is like tender loving care. Somebody asks, "Arey, achi goli घेतलीस का तू?"
That also is true. Thanks so much.
Thank you, ma'am, for the wonderful lecture.
Thank you, ma'am. For our next session, we have with us Dr. Sneha Bhoyer, ma'am. Madam is Managing Director at Sukharta Hospital, Yavatmal, with almost 30 years of experience in the field of obstetrics and gynecology. Madam will be talking on a very common yet very important topic of recurrent pregnancy loss. Madam, I request you to please come on the dais.
A very good morning, rather Sunday morning, very busy morning as far as the religious occasions are there. And I'm very happy to be here to deliver my talk on recurrent pregnancy loss. I can see Dr. Pidvi sir here and so many, Dr. Rohatgi madam, some other seniors also are here. I remember 10 years back, we have started this drive of recurrent pregnancy loss. And that time, everybody was talking on recurrent pregnancy loss. And meanwhile, maybe with so many advances in the preparations also, and so many different preparations of progesterone and types of progesterone also, maybe, we just lost the track and now again, we are talking again on the same subject. So, a topic which is, very, very close to our heart as obstetrician, practicing obstetrician, though little frustrating. And that's a very reason I think maybe number of times we have heard it, but still we try to, apply it to our clinical practice. And I think just a revision for all of you. Recurrent pregnancy loss. 3 or more may be clinically recognized, may it be consecutive or non-consecutive early pregnancy losses, that is before 20 weeks of pregnancy. It can be primary, where you may have never had any successful pregnancy, or maybe you have had some successful pregnancy and maybe in between the pregnancies, you are having this recurrent pregnancy loss. The incidence 11 to 13% for first pregnancy. Sporadic abortions can happen to anyone just like that. But after one abortion, the incidence definitely rises to 13 to 17%. And then after two, 38%, 55% after three. In spite of the battery of investigations we do, we still have a majority which are unexplained, and that is the most frustrating part of it. Though we have certain, that is 50% of the causes which are explained by anatomic, endocrine, immunological, infective, environmental, genetic factors. So, of the clinical significance and which are treatable. So we go to anatomical factors first. They can be congenital, Mullerian anomalies, acquired in the form of tumors, infections, and Asherman syndrome. The anatomical causes which we routinely face can be substrate complete or incomplete, bicornuate uterus, unicornuate uterus, T-shaped uterus, and the acquired ones, the submucous fibroids, intrauterine adhesions, and large endometrial polyps. Now, how do they affect? They can either interfere, they can either reduce the capacity of the uterus, they can interfere with the implantation of the pregnancy, they can interfere with the vascularization, and maybe some of these anomalies can lead to cervical incompetence. So, we have the commonly faced septate or subseptate uterus, which is the commonest anomaly to the tune of 55%, and it is responsible for 25% of the early abortions, and majority, though not 6.2% late abortions of preterm labor. Unicornuate uterus, it represents almost 20% of the anomalies and is responsible for 51% of the abortions. Of course, it can be alone or it can be accompanied by a rudimentary horn. Either it can have a cavity or no cavity. It may be communicating or non-communicating. But yes, if it is having a rudimentary horn with a cavity, then definitely she has to face major problems of malpresentations, uterine rupture, and the ectopic pregnancies. So that is more worrisome if it is accompanied by the rudimentary horn with a communicating cavity. Uterus diadelphys, least common, 5 to 7%, but responsible for approximately 43% of the abortions and 38% of the preterm labor. This is, of course, you all know, because of the failure of lateral fusion of uterus and vagina, and because it is a complete duplication or septate rather, including the vagina is also septate. So it may also interfere with the intercourse, and that maybe, before conceiving itself, she has already been operative for the vaginal septum. Bicornuate uterus, responsible for 10% of anomalies, abortion 32%, and preterm labor 21%. This is, of course, the incomplete fusion of both the Mullerian ducts. Arcuate uterus, should we label this as anomaly, or it is just a natural normal variant? Just complete, it is just near normal, complete resorption of the uterovaginal septum, and uh, the data is also very, very conflicting. Some say 13% abortion, some say 45%, and treatment is, of course, expectant. I'm sure all of you have managed these cases successfully. T-shaped uterus, I don't think any need to discuss this in detail. The diethylstilbestrol tragedy, which was used for preterm labor from 1940 to 1970, it was banned in 70, and yes, the females had major problems as far as the uterine anomaly is concerned. T-shaped uterus, I don't think nowadays we will be having such cases. Uterine neoplasms, submucous uterine fibroids, large endometrial polyps, all these tumors can definitely, interfere with the implantation of the pregnancy. 20 to 50% of all the women, they have fibroids. Should we operate all of them? Then how do we decide? Suppose the women have recurrent pregnancy loss and you don't find any reason and she has a large submucous fibroid. That is a woman who really you want to operate upon. There's no need for operating each and every woman. Iatrogenic causes. Intrauterine adhesions, Asherman syndrome, leads to poor implantation, also interferes with vascularization. And as you all know, treatment is hysteroscopic adhesiolysis, putting Foley's balloon in place, giving hormones. But I don't think whatever you do, all the other anomalies, they have quite successful, fruitful outcome, but Asherman's is quite frustrating. Anatomical factors. When will you labor? Now, after these Mullerian anomalies and tumors, we have cervical incompetence. So how do you? It's not that every patient who is having second trimester abortion just go for prophylactic os tightening. Should we go for prophylactic os tightening? And when do you label the woman having incompetent os? We definitely have a criteria. Cervical length of less than 2.5 centimeter, which is also endorsed by FIGO SUG, and of course transvaginal sonography at 11 to 13 weeks and then again at 18 to 20 weeks should confirm your diagnosis, though both the organizations, they say that there are comparable results as far as the outcome is concerned with cervical encerclage and vaginal progesterone. Now coming to the genetic aspect, chromosomal 3.5 to 5%. What can be the problems? There can be fetal chromosomal abnormalities, parental balance translocation, single gene disorder, alpha thalassemia major, thrombophilia, X-linked dominant disorders. What are the risk factors for genetic disorders? Mainly the gestational age, as you all know, that the earlier the abortion, higher is the chance for just the genetic abnormalities. So 90% of the anembryonic pregnancy or blighted ova, what we label, they can have genetic problems. 50% at 8 to 11 weeks, 30% at 16 to 19 weeks, and 6 to 12% more than 20 weeks. Advanced maternal age, all of you know, If the woman's age is more than 35, she is more prone for trisomy, Downs, recurrent pregnancy loss almost to the tune of 75% in women above 45%. Reason, all of you know, the declining fertility, not only in the number, reduction in the number of the ova, but also in the quality of oocyte as well. Spontaneous miscarriage. Sporadic abortion can happen in 10 to 15% of the cases. Mostly 80% of the losses, as we have said, it is in the first trimester. 50 to 70% of these women, the abnormality associated is chromosomal aberrations. And it can be mainly trisomies, 13, 16, 18, 21, to some extent monosomy, triploidy, and tetraploidy as well. So what are the risks for chromosomal abnormality as translocation, parental balance translocation? In general population, it is 6 in 1,000, that is 0.6%, but in association with recurrent miscarriage, it is almost 4.1 to 11%. So there is definite association of the balance translocation, parental balance translocation with the recurrent miscarriage. Parental translocation can be reciprocal and Robertsonian. You can have mosaicism and inversion as well as. Now, what is this translocation? I will just quickly go over. It is only the exchange of the chromosomal segments between two non-homologous chromosomes. Here you can see the lower ones, YZ and GH, getting exchanged. Then you can have the reciprocal and Robertsonian translocation. In reciprocal, you just have the exchange of information, whereas in Robertsonian, you have the two non-homologous chromosomes. They are breaking at the centromere, and the long arms, they get fused, and the short may be even lost. So this is just the comparison of the spontaneous sporadic abortion and the recurrent abortions. Spontaneous abortion, the incidence is almost 10 to 15%. 50 to 70% of the abortuses, they show chromosomal aberrations. Couple karyotype is usually normal because it is just a single sporadic abortion. But if you have a case of recurrent miscarriage, couple karyotype may be abnormal. It may be just phenotypically normal but balanced translocation. Recurrence risk is negligible for a sporadic abortion, but yes, with recurrence, it increases further. Single gene disorder, we have already said, mainly it is the second, third trimester losses, alpha thalassemia, hereditary thrombophilia, and X-linked dominant disorders. Now, how do we do the, for whom we should do the genetic evaluation? A couple who are having babies with features of dysmorphism, mental retardation, maybe they have had some unexplained stillbirths or neonate infertility, clotting disorders, and of course, recurrent pregnancy loss. Now, what is the role of infections? Here, ovum is the major culprit, 80%, sperm 10%, and uterus 10%. Infections, as you all now, this is not the time to discuss this because torch infection is not responsible for the recurrent pregnancy loss. Maybe for that particular pregnancy, if the woman is having infection, active infection during first trimester, that too, then only we should have this torch infection. Whenever we are investigating a woman of recurrent spontaneous abortions or recurrent pregnancy loss, there's no need or no role for torch infection, and that's the reason it's time to say goodbye to this test. So what infections rather? Mainly the viral infections, Coxsackie and parvovirus infections, bacterial infections, bacterial vaginosis, tuberculosis, and chlamydia. And to support, you have these studies, maternal and paternal genitourinary infections, actually, they have a causal relationship as far as the recurrent pregnancy loss is concerned. And bacterial vaginosis, all of you know, though just theoretically we have these 4 AMSILS criteria, the thin homogeneous discharge with the, which releases amines and it has got a fishy odor by addition of KOH. You have the clue cells and vaginal pH, high vaginal pH that is characteristic. And why we have to give importance? Because this has got a definite causal association with recurrent abortions. 50% of the cases they have bacterial vaginosis, of the infections, 50% are bacterial vaginosis and remaining 25% each for trichomonas and candidiasis. This is just a slide showing you the evidence that yes, chlamydia trachomatis has a causal relationship. Now it's time to look at the sperm. Whenever you have a sperm with DNA fragmentation, if it doesn't repair at all, then there is no chance for fertilization, but it repairs incompletely. It can fertilize, but yes, there is a problem whether the offspring will be normal or abnormal. Unless there is a complete repair of the DNA damage, there will not be fruitful pregnancy as such. Now coming to the immunological aspects, mainly the autoimmune diseases like SLE and panarteritis nodosa, these are the rare, PAN is a rare one actually. SLE many of us are facing in day-to-day practice. But for APLA, the primary antiphospholipid syndrome, what are the antibodies we have been testing routinely and which we should test? There are so many antibodies, but obstetrical significance, mainly the lupus anticoagulant and anticardiolipin antibodies, that to IgG and IgM in medium or high titers. Now, the incidence is quite high. Even in general population, if you do this test, comes positive. About 1% of the couple who have had a miscarriage, it is positive for them. 5 to 20% of the women with recurrent miscarriage, they have these APLA antibodies. But there is a standard method how you should do it. We have to use the standardized ELISA, and then we have to do both the IgG and IgM. Only medium and high titer should be considered. The test has to be repeated after 6 weeks. So all these criteria have to be followed. Otherwise, there will be overdiagnosis. And then, of course, you have to have the diagnostic criteria as obstetric criteria, thrombosis criteria, and laboratory criteria. So at least one from the clinical and one from the laboratory. From the obstetric criteria, you have 3 or more consecutive losses before 10 weeks. Then you have 1 or more fetal death after 10 weeks. And then you have the third criteria, severe preeclampsia or placental insufficiency, necessitating termination before 34 weeks. So these are the obstetric criteria. You can have unexplained venous thrombosis, unexplained arterial thrombosis, and then of course small vessel thrombosis of any of the important organs. Laboratory criteria, we have already discussed that these are the 2 antibodies which are of obstetric significance, and that's how we have to club these 3 criteria. What should be our goal if at all we diagnose this primary antiphospholipid syndrome? We have to see that we avoid the early pregnancy loss. We have to confirm the presence of cardiac activity and then start the treatment with the aim of normalizing the placental function and achieving good or optimum growth for the fetus, prevent maternal vascular thrombosis as well. So women with primary antiphospholipid syndrome, if they have only this diagnosis with no thrombosis, then we start with aspirin and heparin. But women who have had history suggestive of thrombosis, we have to make it mandatory to start with the actual anticoagulant, either heparin or warfarin. This is just the evidence sharing with you, whether aspirin alone or aspirin and heparin in combination. Naturally, the latter has got a better outcome, and that's the reason it's a routine practice to club both these 2 drugs. Clinical tips, I don't think I should, but just to quickly run through. There is a controversy whether we should use the heparin unfractionated or low molecular weight heparin, whether we have to consider, of course, the cost, efficacy, and side effects, everything. But yes, how should we start it? Dosage, you all know, of 5,000 you have to calculate as well. But pre-conception, we can very well continue the woman with warfarin. Once the pregnancy is diagnosed, fetal heart is demonstrated, we have to take her on to heparin. And then second trimester, again, we can shift her to warfarin if you want. If you want to continue with heparin, that is okay. But then you can shift her to warfarin. 34 to 36 weeks, again, you shift her back to heparin, but then it has to be stopped at least 24 to 48 hours. And every third day, you need to monitor for bleeding time, clotting time, the coagulation profile, and platelet count as well. For low molecular weight heparin, theoretically, yes, do we need to monitor, but we have been using it so frequently and over so many years, there's absolutely no problems as far as the platelet count and function is concerned. So I don't think there is a need for frequent monitoring with low molecular weight heparin. As far as the role of progesterone is concerned, so many types of progesterone, so many routes to be administered. I think the discussion will be ongoing for days together. But here, what we have for recurrent pregnancy loss, dydrogesterone is to be preferred because it has got an immunomodulatory effect. That's what I have to say here. Dydrogesterone leads to increased receptor of the progesterone. At the same time, it leads to increased progesterone-induced blocking factor, and that's how it protects the embryo, and that's how it prevents the fetus from getting aborted or embryo death. It makes the balance in favor of TH1 over TH2. That's how we still believe, and we have the practical evidence also to support that, yes, dydrogesterone is a drug of choice for RPL at least. De-stress and assure. Whatever you criticize, tender loving care does have a place. Scientific evidence, yes. Psychoneuroimmunology, stress affects immune system, changes TH2 response in endometrium to TH1 response. Hypothalamus affects endocrine system, and adrenaline release reduces placental blood flow. All these factors, they support the tender loving care. It's not just somebody's, fantasy claiming that, yes, I treat the patient lovingly, so I get good results. Surrogacy, because we are talking so much about these genetic and chromosomal problems, if at all, we do have such patients, yes, because whenever they have recurrent pregnancy loss, one of the partner is affected. So naturally, you have to go for the donor's gamete and go for IVF and PGD and diagnose beforehand. The problem of RPL is still very, very frustrating, even though with such advanced science investigations and drugs, because there can be more than one causes. Each individual abortion may have different cause, and of course, thorough investigation even today fails to reveal the particular cause, and that's the very reason maybe we still have, a long way to go ahead, and we, all of us, keep working and keep sharing your views as well, so that we can help each other and help the couple as well. Thank you so much once again, and thank you all for giving me this opportunity. Thank you so much.
Thank you, madam. It was a wonderful and comprehensive lecture. But as years go on, new and newer things are being added up. Now we have to add vitamin D deficiency, then COVID virus antibodies. So the list goes on and on. Thank you.
Sneha, I would just like to add a few words. That was indeed a very, very comprehensive. You've covered all the points so beautifully, and you always speak so nicely. So thank you so much for that detailing on RPL. One message for everyone is, like, whenever a patient comes to you, the first and foremost thing which you should do is you should listen to the patient. Listen to the whole history as to what she's saying. Was it really an abortion, or was it just a missed period, or was it just not even UPT positive, right? So listening to the patient always helps. Examining the patient head to toe always helps. We keep on missing so many things, right? So many systems are just missed out. Just correcting anemia, looking whether she is having sickling, right? These are few things, or she is having vaginitis. We directly put the probe, TVS probe, ghetla ki we do an ultrasound machine. We don't bother to look at the PS, we don't bother to look at the cervix and the vagina. So few things always helps us. I think we should go back to our days of anatomy, physiology, whatever we've been taught right from the first MBBS and of course our MD medicine, MD gynae lessons. And this always helps us. So COVID has also given us good results. You know, so many patients who have been attempting pregnancy, we've seen that without any treatment, they've come to us getting pregnant. So COVID has taught us many lessons, and the thing is just slow down, right? Tell the patient to have some time, slow down, everything all sets fine. So thank you so much, Sneha, for that wonderful talk, and thank you, Indico, for giving us a chance to chair this session. We, on behalf of Inder, Rupashri, and myself, are thankful to you for giving us this opportunity. Thanks once again. Dr. Modi also, thanks.
I would like to inform that there is a slight change in the program. We'll start with the panel discussion and continue with the lectures later on. So I thank the chairpersons, Murik sir, Rupashri ma'am, and Varsha Dhavle ma'am. Thank you so much. So the session 2 is a panel discussion on doctor-patient interactions and interesting OPD situations. The moderator for this session is Dr. Surekha Taide ma'am. She is a professor, unit head, JNMC Savangi Wardha, since 20 years. The panelists for this session are Dr. J. Fidvi sir, who is HOD of obstetrics and gynecology in 3 colleges for 11 years and is a senior obstetrician and gynecologist. Dr. Leena Birhe Kalmik ma'am, who is director of Gananam Hospital and Research Institute. Dr. Pradnya Gijre ma'am, who is consultant obstetrics and gynecology at Torne Maternity and Laparoscopic Hospital, Lakshmi Nagar. Dr. Shilpi Sood ma'am, who is consultant gynecologist and laparoscopic surgeon at Safal Hospital and Diva Fertility Center. Dr. Anuradha Redorkar ma'am, who is past president of Nagpur Obstetrician Gynec Society and winner of many prestigious awards. Dr. Paresh Gandecha, who is director of Yavatmal Test Tube Baby Center and past president of Yavatmal Obstetrics and Gynec Society.
I request Ujjwala ma'am also to please join, and Varsha Dhawre ma'am. So welcome all the panelists on the stage once it is set. Let me start by wishing you all a happy festive season. We are here in spite of all the festivities, and that is because we wanted to meet each other, I think. And Dr. Rajesh Modi, I should be thanking for providing us this opportunity to be here together in person. We have been meeting virtually for last 2 years, and I think this is the first opportunity we have got to be in person meeting, and it feels so good to be amongst all of you. Nagpur, I have always said, is home for me, and I find it very refreshing to be back amongst all of you. So this is a very different type of panel we have designed. And are we ready? We need one more chair. We need one more chair. So this is an interesting panel on OPD scenarios. I would request all the panelists to kindly, Sir Fidvi sir, please come on stage. So please welcome Dr. Fidvi sir as panelists. Paresh, Dr. Paresh, Ujjwala ma'am, Varsha, are you there? Yes, please come, please come. It would be interesting for to have your inputs here. Pradnya and Shilpi. Sorry, what's it here? Or on that side? उसको बंद कर दे ये ना वर्षा काय होत नाही ग Vaidehi said that you'll be joining. Okay. So can I have Sangeeta then, please? Because this is a very interesting panel and we really want all the inputs, and I request, yeah, please. Yeah. इकडे घ्यायचं का? I think that's okay, ma'am. So greetings from my medical college, which is Jawaharlal Nehru Medical College, and I'm proud that I'm part of this setup now, and such a lot of teaching, learning is going here. And I've just depicted here one very good team, which is about the virtual simulation lab we are having here. And of course, I'm presenting myself as our candidate for Clinical Research Committee, FOXY. So I request all the Nagpur people to kindly support me in this endeavor. So we go on with our panelists, and we do have really, eminent panelists here. We have those have already been introduced. And am I missing somebody here? Yes, Ujwala ma'am. Please, we would like you to be here. Doctor-patient relationship is at an all-time low. As we all know, we have been through the pandemic. There is an atmosphere of distrust on both sides. Even the doctors are nowadays, being afraid of the patients because so many reasons. As professionals, we need to work on what is feasible from our side to, further this bond, strengthen this relationship between the doctor and the patient. Now, as far as OPD is concerned, OPD is the place for first encounter with the patient for all of us. It is the backbone of communication and counseling for doctor and patient. And of course, we find that we are the boss in the OPD. It is our power seat from where we can lead. So I think the OPD is very important, and the interaction between patient and doctor in the OPD is very important. So we have devised the panel in such a way that whatever we encounter in the OPD, it's nothing academic, it is more sort of skill-based on communication and what should be our strategies and approaches when we encounter certain difficult situations in the outpatient. क्या रखा है किसी की धड़कन बन जाने में? क्या रखा है किसी की धड़कन बन जाने में? मजा तो है किसी की धड़कन वापस लाने में. मजा तो तब है कि जब हम किसी की धड़कन वापस ले आते हैं, और सभी लोग यहाँ पे ऐसे ही बैठे हैं जो कई लोगों को हमने धड़कन वापस लाई है. So this is the first case. Mrs. Sunita, she's 35 years old, multiple wake complaints, wide discharge PV, vaginitis, chronic pelvic pain, visited many practitioners. Irrelevant tests are done, some tests are self-advised only. 4 to 5 USGs also she has done from different doctors, and multiple courses of syndromic management she has received. She is non-compliant, she is resistant, and in these USGs sometimes, they say free fluid in the pelvis. That's what few of the USGs have said. Gali gali mein doctors, multiple visits to n number of them, multiple tests done. She's also a Google master. She's plied with advice by relatives also. Ye kar lena, wahan jana, yahan na jana. She finds herself to be half doctor herself. Now she has come to you. You have to deal with her. You have to have your own unique selling USP, okay? Unique selling point or potential. Now this question is for Sangeeta because you are replacing Vaidehi. You suggest that PSPV has to be done, okay? But she is not willing. She has been given a lot of treatment without doing an internal examination. So she is not willing for the internal examination. Dr. Sangeeta, how do you deal with such patients who are not willing to do what you want, or especially an internal examination?
Hello. Madam, in this case, the chief complaint of the patient is vaginal discharge. I will not go with any chronic back pain or pelvic pain or some type of not associated symptoms. She is saying that I am having discharge. So I would like to confirm it. And unless and until she will not allow me, I cannot proceed further. And maybe she might have been horrified by the previous sudden per speculum examination. So the role comes of, here you can say, tender explanation rather than loving or this, just a tender explanation unless and until I would able to see whether you are really having a normal discharge or abnormal discharge confirmation. Then only I would, by my counseling, I would take her in confidence to do her local examination.
Yes, so it's very important that when patient comes to you and she has been going to multiple places, it's very important that you establish some communication with the patient. And we have been doing this for so many years. Now we know how to judge what is going on in the mind of the patient. You know, as a doctor, we always try to think what is happening in her mind, and probably here comes the very important role of communication and counseling, sitting with the patient and trying to imagine what's going on, and then of course trying to find out, and then whatever you want, especially a clinical examination is so important, and that is where I think the communication. So Dr. Fidvi sir, did you encounter such patients in your medical college also who refuse examination? And what is your strategy? How do you deal with, what is your unique strategy? You do have unique strategies, so we would like to know about that.
See, the question which you are saying is, do they resist? When I joined medical college, that time males were, and that time the question of doing all this, you were not permitted only. You were asked to sit, go take BP, go take weight. And as the years passed by, you have to have the patient gain full confidence in you. And when she comes to you, if she has a full confidence, whatever you say, she would not resist. Because I have seen, it's so many years that I told you the initial beginning, and as I climbed up many steps, and the scenario in the OPD changed, because I was the senior person, I would go 10, 15 minutes late, patients waiting, sitting, and as soon as they would see me going to my OPD, they would snatch the OPD ticket from my juniors who are all
Definitely.
sitting there and coming to me for this. And they would never resist. And first you have to tell her that you have been doing all these things and you have not got relief. And I have to do what I have to say. And if you want a better treatment, I have to
Definitely,
go with this.
sir. What we get the message from here is, as you gain experience, your presentation itself, your presence in the OPD and your demeanor, your confidence, everything conveys to the patient, yes, this has to be done, and that's all. So that reputation and that confidence has to be created. You know, by your unique personality itself, you can create, and I think that's a great learning point from you, sir, that of course we need to gain the confidence, and that's what it gives us. So, and Dr. Paresh, sir, yes, sir,
let me.
please.
Since I was for 35 years in Mayo Hospital, which is all surrounded by a Muslim area, even with this surrounding, I never had any problem patient refusing it.
Yeah, definitely, sir. I think that's a plus point for your personality, being a male gynecologist, and then again having that religious sort of a inhibition. Still, the patient were allowing you. So I think salute to your confidence and your personality, which has, and that's what I think all the maybe the students are there or not, or the early career individuals can learn from you. Thank you for that, sir. And Dr. Paresh, what about these Google Masters? How do you deal with this? Google Masters who come to you, and what is your unique strategy to deal with Google Masters?
I think these kind of patients are normally attention-seeking type of patients, so they need you to listen to them properly. So what we need to do first is to let them talk whatever they want, try and understand what they want to talk about. Most of the time, they have read something in the Google page, and which is most of the time relevant. Whatever they read is about their own disease, and they try to guide you towards the diagnosis. If you disagree with them, tell them politely, no, I don't think you have this kind of a problem. Let's investigate you in the different direction which I am thinking about. you read about it in Google again and come
Yeah.
back to me tomorrow.
Yes, definitely. So first is paying attention to what they have to say. Okay, let us listen to what they say, and then what your point is, your experience is. So ultimately, we have to tell them, ki, please don't confuse your Google search with my medical degree. And of course, that we don't tell them openly. Our own way of talking with them will tell them, okay, we have more knowledge. Our so many years of experience actually will. So again, that's important. Again, your communication skills, your rapport building, your experience, everything will come to your help when you have such kind of. And we have n number of patients every day, day in and day out, they come reading from the Google. So here is another case scenario
Hello.
with me, Mrs. Geeta. She's a
Hello,
homemaker.
he wants to say something.
Madam, there is one more addition here to the Google Masters. Sir has suggested that you need to talk to them and ask them they are not going to appear for an MBBS exam. So let's not discuss about this.
We have to tell them politely that because Googles, they read and they come and they ask you questions. Tell them politely that you are not appearing for exam and humbly request them goodbye, go wherever you want.
वो तो है सर, पर हम लूज नहीं करना चाहेंगे ना अपने पेशेंट्स, ज़्यादातर तो हम रिटेन करना चाहेंगे. तो देर इज़ ऑलवेज अ वे ऑफ शोइंग, यू नो, कम्युनिकेटिंग दैट व्हाट इज़ बेस्ट फॉर देम. I think politely, and we can really, because see, being an institute, being in a private practice is little different way of dealing, I think, and that's where I would like to have the opinion of both the sides. You are there representing the institute. Let's go and talk with this another patient who is a homemaker. Husband is a bank employee. She has 2 previous abortions, and now she has a USG, few lab tests done, some relevant, some are irrelevant. You want to advise APLA test, ANA test, TSH, prolactin, and so many other tests. You also want to do a 3D ultrasound, then you want to do a hysterolaparoscopy. Cost is going to be high with these all investigation. My question is to Pradnya, what about if you have a huge number of investigation to advise? Do you have a way, a strategic approach? How do you go about? You have some investigation and then you have special investigation. How do you have an approach for it?
Thank you for the question. My approach will depend upon the age of the patient. The patient's age is not mentioned. If she's young one, then I need not rush into all the expensive investigations. From the history itself suggests that she has must be having some blood coagulation problem, which needs to be conveyed to the patient. And the basic biochemical test can easily be done. And as it comes to expensive investigations, what I've learned over time is not to decide for the patient. Give all the information, give the necessities, why the investigations are being done, and let the patient decide. Many a times I've experienced that the patient you feel is not going to spend so much. Instead of deciding if you convey the information to her in the right fashion, 8 out of 10 people decide to go for the investigation, especially the expensive biochemistry investigations. Most of the patients, they agree once you tell them the information and the reason behind it.
Yeah, definitely. And also, if you have a number of special investigation lined up, I think we can tell them in a, sort of batches. You tell them first investigation, and then when they come to us with the reports, we can talk about the later, like if you want to do a hysterolaparoscopy, then you can tell after they come to you with the biochemical analysis. So don't give everything at one go. That is maybe a strategy, and you could tell them to do it where you call them again, and then maybe you talk with them again, so that you don't frighten them with the whole battery of thing at one go. So that may be a strategic approach. Now another belief is that,
can I add something to that?
Yeah.
You can even tell all the investigations that need to be done in a stepwise fashion right in the beginning. So next counseling session, you can go back to the previous notes and tell her, okay, this is the next thing now which we have to go for.
Sometimes we face with patients who think that there is some linkage between this lady, the doctor, and the pathologist. That's why she's sending us these investigations. So how do you deal with that kind of people? Shilpi, do you find something in your practice, and how do you deal with it?
Yeah, it's as we have already discussed, the cost of all these tests are very high, and you can see with the case we can concentrate on the like APLA is more important diagnosis, so we can start with these tests in the initial step, and
Hey,
later on.
my question is different now. My question
Coming
is,
to the
disbelief and these beliefs and misbeliefs. You know that there is some linkages between the pathologist or doctor, इसलिए वो ज़्यादा आपको investigation बता रहे तो. How do you deal with that?
we can get away with this belief of patient, in fact, by giving them an initial test which are less costly and not putting them burden of all the tests at a one stretch, or we can give a choice like you can do anytime whenever you
Exactly.
want. And
So that is
wherever
what
you
the
want,
message.
wherever you want.
Wherever you want. Do not specify any pathologies or any lab or anything, and you do it wherever you want. So if that kind of beliefs, you can just take over by, wherever you want, you can go, not necessary that this particular pathologies only. So that what message I wanted to actually by this. And again, Dr. Paresh, I would like to ask you, how to get over barriers of mistrust and disbelief in your own practice when you find that these people are not believing you? A general question.
The filter to know that whether your patient is going to believe you or not is the first question they ask you. If they ask you, hey, investigation karna zaruri hai ka?
Yeah.
That's the indication that you need to counsel her a little more, give her a little more time, and tell them why these investigations are necessary. Whenever you advise investigation, please tell them why they are necessary, why you are doing it, what kind of results you are expecting it from it, and if the results are this, what are your next step of treatment, and if your results are different, what will be your line of treatment, and why these investigations are necessary, because they are going to change your line of treatment this way, so you have to do it.
Ujwala ma'am, you want to add something on this?
And the second thing is they'll tell you कुठं करायचं.
कुठे करायचं?
Then you have to say कि किधर भी करो.
Idhar bhi karo, but if you have specific hormone, see these, hormones.
You have to give a panel of
to tell them.
laboratories.
There are certain labs you have faith on, maybe, probably.
Then you have to give them the list.
Here I will like to add one thing. What the general belief in the patients is half correct also. Okay, you cannot deny that fact. Another thing, in the Nagpur, we can ask them which labs you know or in relation you are, and then we will analyze, yes, whether we to believe in these labs or not, and give them a choice.
Yeah,
Yes, you can
definitely the participatory approach and giving choices, informed choices, I think is much better, so that we can bridge these gaps, of distrust and misbelief which we are finding here. तो रिश्ते और विश्वास दोनों ही मित्र है. रिश्ते और विश्वास दोनों ही मित्र है. रिश्ते रखो या ना रखो, पर विश्वास जरूर रखो. जहाँ विश्वास होता है वहाँ अपने आप रिश्ता बन जाता है. And I think that's true, very much true for the doctor and patient relationships. Trust is always earned when actions meet words. So we have to also behave in that manner that our actions are meeting our words, and that's why that is the way where we can build this trust and these relationships, I think. So let's go and move to the third scenario where there's a previous cesarean section patient, 34 weeks, she's having high blood pressure. She has been advised admission. This couple has some political connections, and इसका उसका phone उसके लिए आता रहता, पहले भी आया था. So you know that there is something, some aura behind this patient. You want to admit her, she's not ready. She says पिछले वाले डॉक्टर ने तो ऐसा कुछ नहीं किया था, कुछ ब्लड एडमिट नहीं किया था, आप क्यों करना चाह रहे हैं? There is that query in their mind. So again, Sangeeta, previous doctor did not deal with the same condition in the same way. How to deal with it? What is your way?
This one LACS at 34 weeks. See, My
question is very general. Your previous doctor has not done the same thing for the same condition. She did not admit. You want to admit. How do you go about it?
For the same situation.
Yes, yes.
See, it's like this. I would like to ask them ki if you have gone for the same complaint to the previous doctor, why did you leave that doctor and came here? One thing. Second thing is, I am seeing you for the first time. I do not know anything about your about the progress of your pregnancy. This is the first reading which I got, and I am finding it to be supervise. So this is my advice. I would like to
Yeah.
admit you and keep you under observation. I am not taking any drastic step of terminating your pregnancy. I would like to
My only thing I would just like to suggest that if your colleague has not done the same thing, I don't think that we should counter that. Our way is different. Okay, so best I think approach would be to not go against anything what the other doctor has done. Just not comment about it, but you convince your way why you want to get her admitted, what are the problems, what complications can occur. If you talk with her more, maybe your approach, your reputation in the market, because this is a consumer market as far as doctors are concerned nowadays, we have lost that the noble profession thing. So your own approach is important, your counseling is important, but I don't agree that we should say that unke paas wapas jao. That may not be the correct way. Just by your explanation itself will and as far as politics is concerned, if there is a couple who is having political connection, I come to that questions later. Sir, do you have these kind of problems in your setup? Patient is not willing for admission, so what do you do?
They are, because where she's staying, how much help is available at home, all this, there are so many problems. But since the patient has problem, you have to explain to her, is, see beta, these are the problems, and what would happen next you do not know, which I can see. And if you don't want to go through all those bigger problems than this, then it is better for you to stay for an observation for, say, 24, 36 hours. If everything is fine, then we send you home back. Or otherwise, if we find something which is deterioration, then we keep you in.
Sir, कल ही एक patient OPD में आई थी. She was having complex heart disease. We wanted to admit her and but बिल्कुल मानने के लिए नहीं तैयार थी. 1 साल का बच्चा था उसका, उसको बच्चे के पास रहना था और बिल्कुल भाग गई वो. She ran away and she was there at the gate. And so anything we can do at this situation, because something may happen to her, she may collapse later on. So are we going to be held responsible? How do you deal with it?
Then what you do is, after explaining everything, if she is not writing, please make a note in your paper that after being
Definitely, I
explained
think
everything,
documenting here is very important, that you tried your best and this patient has this complication, this could happen to her, you document on your paper. कि ये हो सकता है, and that I tried, so that documenting and keeping that paper with you. Sometimes we document on the OPD paper and then the OPD paper goes with the patient. You don't have any proof in your hand that something happened, such kind of encounter happened in the OPD, so you should have the counter copy with you also. Sometimes it has happened that patient has gone somewhere else and there's a maternal mortality and there was a question. So I think that is very important to note that.
and it would always be better for you to counsel the persons who are accompanying her. That would also make a difference, because they might be wanting her to get admitted, but she is not willing.
Yeah, yesterday we had the ASHA worker who accompanied. So we counseled that person. Yes, now you have to have a middle party also, wherein you can deal with the patient who is having such. So that's a very good suggestion from your side. Thank you for that. Dr. Paresh, ये political वाला जो मुद्दा है कि threat रहता है कि मैं तुम्हें देख लूँगा बाद में अगर तुमने ये हुआ तो वो हुआ तो, उसको कैसे आप deal करते हैं?
Normally, if these kind of people you are going to encounter and if you don't want them to be in your hospital, the most polite way to send them is to send them to higher centers. And these things we may have to give it to you. And unfortunately, I don't have that facilities with me. So please, I am giving you 5 more options which have tertiary care facilities. Please go ahead and choose any one of them.
Ujwala ma'am, do you do the same thing?
Yes, I see this. I had experience in last month. I had a patient, elderly, 40 years, with sickle cell anemia, with PIH, altered raised alkaline phosphatase, and she wanted me to have the cesarean section on 15th of August, where I had suffered that no blood bank is open. Then it's very difficult for such a patient. And ultimately, I asked her, sorry, if you come and I'll get it done on 14th, Otherwise, you can find out your ways. And I lost that patient. She went somewhere else and she got her ego satisfied.
अच्छा, पर हमारे पास वो नहीं रहता ना. We are in an institute. One patient comes to us, then we have to deal with them whatever way. We cannot send them to the higher center.
Yeah,
So
this is usually seen in government medical colleges where you may not be influenced by a political person directly, but your dean gets the phone call and then he tells you. So it is better that whatever we can do best, you tell them we are trying and tell the dean, please convey that the best person is treating
I think
the person.
that's the best attitude, that you do your best for the patient. You always do your best effort, and that actually has created a reputation also, and maybe that's why the dean is calling you also. And so you have to maybe use the dean as a pivot, to convey the message to the couple about the need maybe for the admission. So you can use the situation in a positive way also. That is what we want to give a message, because every time we may not have the option of sending the patient somewhere else. So we have to have our unique strategies for dealing with such.
Even involving the influential person would be a good idea, and making the person sign all the informed consents becomes a party to your.
So when someone says dekh lunga, so there is option of saying chal nikal, but may not be possible all the time. So we have to be diplomatic most of the time in dealing with patients, with persons who are influential, maybe not political, but influential. So chal nikal is always not a good attitude. You have to have a polite way of doing things, and trying to find ways out of. So we did have such experiences in the pandemic also. They used to tell us, okay, ये करो, वो करो, रेमडेसिविर दो, ये मत दो, वो मत दो. तो क्या जरूरी है और क्या जरूरी नहीं है, that we as an expert, we know, and we should have our conviction and confidence in what we are doing. So let us talk about this, the other scenario where a 32-year-old, she has an HMB, heavy menstrual bleeding, you have provided progesterone, she has missed the progesterone, and she's coming back to you with intermittent bleeding. Now the husband is blaming you कि आपने इंजेक्शन क्यों नहीं दिया, आपने गोली क्यों दी, आपकी ट्रीटमेंट गलत है. तो they trying to find out, they're trying to blame you for what was done. So Dr. Pradnya, what about these non-compliant patients? What strategy do you have? This is not only about progesterone, it could be about anything, your iron, your anything. So many things are there where compliance is so important, and do you have a strategy for it to have this compliance?
I always make it a two-party thing. Like, I am the expert person giving the information, and the decision-making responsibility I keep on the patient. I never make decisions for them. I ask her whether she is regular in taking her medicines. Otherwise, missing a hormone tablet would get her into more unpleasant kind of bleeding. So if she agrees that she'll go and try with the medicine first, then I tell her, if you are not able to go regular with it, the next step would be injection or a intrauterine hormone device. So you give a trial, or if you are not regular with taking medicines, we directly go ahead with a method where you don't have to remember and pop a pill on a daily basis.
And then we can take the help of some relatives also. If there's a young girl who has to be given that hormonal treatment, maybe we could take the help of the mother to remind her, or the husband maybe could be reminding her. So such reminders, there is some such strategy in the DOPS, the treatment of the tuberculosis, where the ASHA worker herself gives the tablet, to the patient. So, or you could have some strategy of finding out how many tablets have been used, and maybe if something is missed. So you could have your own strategy to see that the compliance is there in this patient. So we move ahead.
Apart from your ASHA worker or mother, the best friend now is telephone. Tell her that put an alarm at this time, and when the alarm rings, the tablet should go in.
Definitely. It also is for this Eltroxin tablets, sir, which has to be taken 1 hour prior and all.
Or you're giving her 21 tablets, and you have to explain her that if she misses today, please take double tomorrow and continue properly.
Yes.
And also tell her that she can keep a packet in the cover of your telephone as soon as it rings. alarm rings, please, the tablet
Very
should go
nice
in.
strategy, sir. And what about, Shilpi, what about if something goes wrong and the patient start blaming you now? What are the solution for such kind of scenarios?
See, since beginning we have been talking about like somebody has to be there, like husband should be in scene, like what treatment she is taking, and she should be advised like if she won't take, she might bleed. Many of the patient, they don't know if they miss single pill they will start bleeding. So that particular knowledge has to be given to the patient, and she should be given like if you take the treatment regularly you will be really safe. If she will not, she cannot blame you if you give her all the informed choices of the treatment, as Dr. Pragna has said, like all the other choices, like if you won't comply with the tablets, then you have to go for injections, then go for a Mirena insertion kind of treatment has to be there. So if you give all the treatment options very well explained to the patient, then this is a good solution. Even if something goes wrong, they have to accept that all the information has been properly given to you. So giving them all information is important.
Yeah. So again, there comes the role of information, informed choices, and if you have a huge basket of things to offer, then you have to explain what basket is for what, and again the role of counseling, and again. So when we talk about the choices, and once the patient chooses one thing, then you have to say you are free to make your choice, but you have to remember that you are not free to from the consequences of the choice. Once you make the choice, then the consequence of the choice, the responsibility of the choice is your own. So that's important, ma'am, from your side?
Yes, absolutely. Very, very important message, because as a gynecologist, we all the time convince the patient, save the uterus. And such patients sometimes, because of the husband, they get to somewhere, usually to the surgeons, and get hysterectomy done instead of all these things.
So once the patient makes the choice, then of course the responsibility of that choice goes to the patient. That's very important that we have to share, and mostly the responsibility of choice once it is made goes to the patient. So let's go to the next patient, and it is about preconceived ideas. They have something in their mind which is going on. So as madam said, she is a 38-year-old only. She has taken medical treatment for HMB off and on. She doesn't have any organic pathology, but she wants to do hysterectomy. So this is, I don't know, madam, how you got to know about this case, but she wants to do hysterectomy. She is hell-bent on doing hysterectomy, but you don't want to do it because age doesn't fit, indication doesn't fit. You want to prescribe her progesterone, you want to prescribe her Mirena. She asks you, क्या guarantee है कि ये work करेगा? So now is your question to you for Sangeeta. What about if you know that if you don't want to do surgery, someone else will do it. If you don't do it, she'll go to some other practitioner, but she will get it done. Still, you want to continue your conservative management. How do you go about it? आपका कुछ खास approach है वो हम चाहते हैं आपसे.
Yes, in this case, considering her duration just 6 months and she has not taken any specific, I would just like to explain her. The hysterectomy is always there, but it is irreversible. If I would like to start with medical management, there will be no loss, only you will gain, or there will be no result, but you will not lose anything. And if it works, so it will be wonder for you. You have come prepared for a permanent operative procedure, and I am advising you something which may either help or it will do no harm.
Exactly. So very nice. And what about this, sir? Guarantee है क्या? Guarantee seekers का आप क्या करते हैं?
Means regarding this HMD.
Anything, इसकी क्या guarantee है कि ये अभी हो जाएगा तो
for
मुझे
this-
bleeding होगी ही नहीं?
For this patient, 38 years, direct hysterectomy, I would not advise. I would say,
सर ये हो गया. आपके पास बहुत पेशेंट आते हैं कि गारंटी है क्या इसकी, तो आप गारंटी देते हैं कि नहीं देते, ये मुझे पूछना है.
गारंटी मैं जब दूंगा जब मेरे को पता चलेगा कि वो यूट्रस के अंदर पैथोलॉजी क्या है.
वो भी प्लस ऐसे ही जनरल में सर पूछते हैं ना पेशेंट कि अभी सीजर कर लेंगे तो गारंटी है कि बच्चा ठीक हो जाएगा, ये गारंटी है कि ये हो अभी दोबारा मुझे नहीं होगा, या फिर पेशेंट पीसीओएस की पेशेंट है, इरेगुलर मेंसेस के साथ आ रहे हैं, आपको गारंटी देनी है, तो आप गारंटी लेते हैं क्या?
Okay. Then In another word, I tell her, अभी तुम रोड पे जा रही हो, गारंटी है क्या तुम्हारा एक्सीडेंट
That is
होगा?
what I wanted to hear. So big hand for sir. किसी चीज की कोई गारंटी है क्या? जब मेरी खुद की जिंदगी की कोई गारंटी नहीं है, मैं चलते चलते मुझे कुछ हो जाए तो मैं आपको कौन होता हूँ गारंटी देने वाला? I can just make my best effort. But definitely, as a doctor or as anything, we cannot give guarantee for anything. So even if you are a great doctor or skilled surgeon or whatever, there cannot be guarantee for anything. क्योंकि यहाँ पे जिंदगी की गारंटी नहीं है, कौन कब कहाँ रहेगा, तो किसी चीज़ की हमने गारंटी नहीं लेने है. डॉक्टर परेश, आई वांटेड टू अगेन आस्क यू, प्री कंसीव्ड आइडियाज के साथ लोग आते हैं, जब मुझे यही करना है और वही करना है, तो आप क्या करते हैं?
They are normally attention seeking people again, and they want whatever they have decided. So most of the time it is a prudent idea to go with their idea rather than trying to cross them all the time. But before going with their own idea, if I feel like they are not doing it scientifically correct, let's take 5 more minutes to explain them why you are thinking in the opposite direction and why should they do the other thing and not the same thing what they want to do.
Exactly.
That's it.
Instead of crossing, we can listen to them. And of course, क्यों उनके दिमाग में ये आइडिया है आई है, ये पहले हम we can try to find out and then make our own.
Most of the time, for their preconception ideas, they have some family history. Like they want hysterectomy done because somebody has died of uterine malignancy.
सिजेरियन सेक्शन करना है ऑन डिमांड, क्योंकि वजाइनल डिलीवरी में कहीं कुछ प्रॉब्लम हुआ है, मे बी फैमिली, मे बी फ्रेंड, मे सम हॉरर स्टोरीज दे मस्ट हैव हर्ड about some sphincter injury, something has happened which you need to find out and maybe allay their fears and make your own point. Is that what you want to say?
Listen,
So that
what I want to say one more thing is, because she has had 4-5 USGs and previous people would have imbibed into her brain that अगर नहीं निकाले तो तुम्हारे को कैंसर हो जाएगा, and therefore she is insisting for a hysterectomy.
So we need to agree that somewhere something is wrong, and maybe in the fraternity also something is wrong and which we need to address. So we cannot guarantee success. We need to only strive for what could be the positive outcome, but we really cannot guarantee anything. That's the message. So next about non-medical management. Again, जैसे कि अभी PCOS की पेशेंट है, 30 BMI के साथ आई है, इवेलुएटेड, मल्टीपल OBT विजिट्स हो गए हैं, मदर अकम्पनीज, क्राइज कि इसका कुछ तो करो डॉक्टर, इमोशनली सीक्स हेल्प फ्रॉम यू, यू हैव एडवाइज लाइफस्टाइल मैनेजमेंट, वजन कम करके आओ, पर आपकी पेशेंट इज नॉट कंप्लाइंग विद इट. Now, Pradnya, how do you deal with this? When you seek equal participation in the treatment from your patient, but patient is not agreeing. So how do you have any strategy you have कि guaranteeing कि जो आपने non-medical part बोला है, lifestyle management, वो follow कर रही कि नहीं? How do you ensure that?
Well, a teenager is really difficult to handle, and especially they are rebellious when the people at home, like their parents, are insisting on certain things and pestering them with that. They become more resistant. So this needs counseling of the mother as well as the daughter, and the daughter needs to be treated like an individual, not in a patronizing way. And the explanation what will happen of a PCOS, what risk they are having ahead in the long run, has to be instilled into them, and let her take the responsibility for her future. She can avoid so many things if she goes with the lifestyle adjustments.
Yes, so treating an adolescent as an adult who has her own personality, I think that's the message to be given. And also seeking help from your colleagues. So if there is a weight management specialist in your town, maybe you should seek help from that person and not try to do it on your own. Maybe you can have a team who could help you with this lifestyle management. And
Dr.
I think
Taide,
yes.
here I will like to add one more thing. We have lot of yoga center in the Nagpur, and especially charitable also. For these girls, there are few asanas and mudras which relieves their stress.
Yeah.
That is more important cause of the obesity in this adolescent girl. And this yogasana, by just joining, because nowadays we have seen the girls, they have put on 15 kgs in 1 year.
Definitely. This pandemic again, sitting
Pandemic.
at home, stress, And not only adolescent girl, infertility patients also, so many patients. So if you have anything which you want to do, which is away from your specialty, like you are not a weight management specialist, but you want to advise, so you could take help of all these
Yogasanas and all.
other specialists also where you can. So that is the message to be given. And what about
And is कि you have to talk to her, you have to counsel her and tell her कि भाई अभी what she's doing, which exam she's appearing for NEET, she's preparing for this, therefore it is like that. And if she's not doing none of this, you have to explain to her कि you are the doctor yourself, you need not come to me. Once you reduce your weight, you would look nice. There would be so many people looking around you if you reduce your weight.
Yeah, so
How do you do it?
So lateral benefits of doing the things also you can
Even involving the mother
Mother
in
and
the sense, become the change you want to see in your child. So the whole family participates, eats healthy food, wipes the kitchen of all the unhealthy food, nothing stored in the house for her to binge on. So that will help in a long way.
I wanted to ask about this emotional crying and frantic appeals for help from the mother. How do you deal with this? You're not God. You're deemed to be God, but you're not God. How do you deal with these
Definitely,
situations?
these situations are very difficult. In fact, we have seen many young girls and mothers are sitting for long. डॉक्टर साहब कुछ नहीं हो रहा आपके ट्रीटमेंट से इतने दिन से आप 21 days की मेडिसिन खिला रहे हैं और उसी से ही पीरियड आ रहा है. So we have to tell them they are essential to have these pills also. Unless they will take the pills regularly, they won't reduce the weight. So every aspect of the treatment has to be explained in details. As I said, the whole family members should work hand in hand with the particular patient to reduce the weight. They should join the patient for the exercise, dieting, home management should be like that. The whole environment around them has to be changed. Then only we can work. In fact, giving the address of the dietitian and the endocrinologist where we can work out with other joint efforts of other fraternities to help out with the weight reduction has to be very. We cannot be God for this thing. We cannot be. We should have to tell we are not God.
We are not God. Maybe PCOS, it is infertility, whatever, we are not gods, and that we have to impress on them. What about treatment failures, Ujwala ma'am? आपने सब कर लिया, अब नहीं हो रहा, तो आप क्या करते हैं?
The first and foremost is we have to investigate her for hypothyroidism.
आपने सब कर लिया, investigate कर लिया, सब हो गया, everything is failed. Now what she has come to you in the OPD, सब कर लिया, ये भी कर लिया, अब क्या करते? Fertility के लिए आपने सब कर लिया, बच्चा हो ही नहीं रहा.
19-year-old girl.
नहीं, दूसरी patient, general बात कर रही हूँ कि what about treatment failures? How do you deal with them? Patient is coming again and again to your OPD. You're not, the success is not there.
So here again is the role of tender loving care and the productive time for the couple. We just listened to Dr. Varsha. She was saying that without any treatment they conceived.
नहीं हो ही नहीं रहे ना, टेंडर लविंग केयर भी दे दिया, सब हो गया.
Somewhere we have to find out something is not being done. We have to find out.
नहीं तो आप अपने ही पास रखेंगे क्या ऐसे पेशेंट? मेरा ये कहना है डॉक्टर परेश, आपके पास 1 साल से 2 साल से पेशेंट आ रही है, कुछ भी नहीं हो रहा है. आपने सब कर लिया.
The psychologist is also one of the important factors.
Yeah, I agree, madam. You have done the counseling, you have given tender loving care, you have done everything possible strategy जो आपको आती है, सारे skills का इस्तेमाल कर लिया आपने. अब नहीं हो रहा है, अब क्या करते हैं आप?
I would like to tell them the real fact, whatever is going into my mind. Like, I have treated you for infertility, I have done your IUI. So I don't know how good is your oocyte because they have the follicles have ruptured inside.
If you
I
could,
don't know how it is. So
आपका खत्म हो गया जहाँ पे expertise. उसके ऊपर कुछ है तो डॉक्टर शिल्पी.
Let the patient go actually now. Let the patient go somewhere and then they will find there is nothing with another doctor also. She might come back to you, nothing has happened and now after 6 months she is with you again.
And it's nothing wrong to seeking help from maybe a senior if you are. So you may, I may be a professor in a medical college for 20 years, but my skills are limited. And if there is a skill, a better skill, who is updated person, maybe younger also, we can seek help from that. So seeking information and help and update from somebody else is not wrong. RPL patient है, bad obstetric history की चौथी बार आई है, अभी 7-8 weeks में 8 weeks में फिर से demise हो गया. आपने सब कुछ कर लिया, LMWH दे दिया, सब दे दिया, फिर भी demise हो गया. So I think seeking information and help maybe from Rohatgi madam, somebody else, some updated person maybe. So it may be a good approach. You may also give an option to her कि आप ये डॉक्टर के पास भी जाके एक बार देख सकते हैं, जरूरी नहीं है. तो I think that could be an approach where we can talk with the patient. So when our skills are over, trying to find out if the help can be sought from any other place for that person may be a good idea. Yes, Dr. Fit.
What I say is, now since everything is normal, I have treated you, and why it is not effective, it is only GOK. Then they ask you, what is this GOK? Why this is not happening? So I say, God only knows, please ask him. That's it.
सर अभी तो ड्रग्स के बारे में एक और भी है कि भाई करंटली 9 out of 10 drugs are experimental and there may be a failure because these drugs have been tried in animals and अभी जैसे बहुत सारे एंटीवायरल्स जो है ह्यूमंस में ट्रायल्स हुए नहीं है. वैक्सीन के बारे में अगर हमको कोई पूछ लेता है कि वैक्सीन इफेक्टिव है क्या, तो भाई ये हमें उनको ट्रू फैक्ट्स बताना जरूरी है कि सम treatments may fail and we cannot take responsibility, so we have to tell them the truth what it is and maybe they can take their own decisions then. So
Sorry
coming to
for
the
interruption, ma'am.
Yes,
Ma'am,
your time
actually
is
it's
over.
Yes.
Yeah,
yes,
so
ma'am.
thank you for that and we come to the maybe the last slides. So this slide is about taking informed consents. So about informed consents also एक मुझे पूछना था सर. लास्ट जब हम informed consent लेते हैं तो हम बोलते थे get the informed consent recorded. कई बार ये सजेस्ट किया जाता है कि आप रिकॉर्डिंग कर लो. कितना ये feasible है डॉक्टर परेश? Do you record your consents?
Let me talk to you practically, it is not feasible. Yes. Ideally, normally everybody is in private practice taking a blanket consent with everything mentioned into it. And we assume that patient has already understood that. But then the most important point is it has to be in a local language. And if it is handwritten, has got a more value. So if you talk to them, better get them written in their handwriting in the local language.
जरूरी और this suggestion that you get it recorded, I don't know how feasible it is.
This is very good suggestion, but then it is not practical all the time.
ना हाँ मतलब हाँ yes.
For writing down, you can ask your hospital staff also to write it down for them and read it to them and then get it signed from them.
These multi-speciality hospitals or bigger setups have a counseling room where you are counseling, everything is being recorded and a person is also writing what you are counseling and then it has to be signed.
नहीं recording का कुछ app है क्या?
You can in the terminally in cancer patients, there is all this counseling is being recorded. So the days are not far away. It may come to our obstetric practice also.
Shilpi?
Sir has really rightly said we have to modify ourselves. Now, the setting up a room with counseling can be done in where we have a space and like proper audio visual system has to be there where we can do important counseling.
Yes. So from the audience we have an input.
App is definitely, we have a softwares attached in our system with apps also.
Yes.
Which were?
Even if you don't have an app, a simple CCTV with a recorder is good enough.
Yes.
You can just record.
So do you record every OPD encounter?
Every OPD encounter.
So I think the nowadays have come because of the disbelief and misbeliefs and distrust that we have to modify our ways. And I have been recording some difficult situations where there's a problem, but not all. So maybe if you find that there is something wrong, the relatives and the whole family is behaving in some, maybe something has happened in the OT also. There's PPH, you want to, so maybe those situations can be recorded, but not all.
One more thing, instead of just recording the difficult cases, it is better to record all cases because a simple case can also turn into a medico-legal case. So
I know, but when there is a high volume caseload like, a medical institute, it's very difficult. So maybe the challenging cases you could record. So you have something in your, so because sometimes they will say, ये आपने जो लिखा है मुझे पता ही नहीं. Court of law में चलता नहीं है. So maybe a recording, but again,
one small point to add into it is if you are counseling in your OPD, you have a camera to record. And adding one more voice port will cost you around 300-400 rupees. Yeah. Just you can add a voice port to it, it will be automatically recorded.
Last scene, and this is for general everybody.
patient needs a hysterectomy, your cost is 25% more than the market. आपका cost ज़्यादा है, तो आप कैसे explain करते हैं इसको? Cost क्यों ज़्यादा है?
Maybe what type of surgery you are doing, or what type of setup you have, and what type of instruments you are using, and outcome of the surgery in your institute matters a lot. So that may
और
justify
दूसरी बात, जब वो पेशेंट सब कुछ जान के आपके पास आई है, तो उसको पता ही है कि आपका कॉस्ट ज़्यादा है, उसको पता है कि कौन से सेटअप में वो आई है, एंड डेफिनेटली यू कैन नॉट सी एट प्रेजेंट वी हैव द फ्रीडम ऑफ इन फिक्सिंग आवर ओन प्राइसेस. That depends on the skill you have, the setup you have, the reputation you have maybe. So that's why your cost is more, and maybe that could be. So definitely cost
For this
crunches are
question, may
there.
I ask Dr. Rajesh to put some inputs into it?
Yes,
He's the best person to talk about this.
I have this. And what about the last question is cost बता दिया, सब हो गया. अब वो ओपीडी में आके हंगामा कर रहे कि हम इतना पैसा नहीं देंगे. डॉक्टर परेश, पैसा नहीं देंगे हम.
If you have already counseled pre-operatively, there is no
नहीं
question.
देना है हमें. झगड़ा कर रहे हैं आपके साथ, लड़ाई पूरी हाथापाई पे आ गए.
Okay, तो अब ऑपरेशन हो गया है.
कुछ हो गया,
आपको
ऐसे
अभी
नहीं
पैसा-
देना है.
बहुत कंसेशन करके भेज दो उसको.
आप करते हो सर? आपको
Yeah,
तो face नहीं करना.
honestly speaking, I have never encountered this kind of a situation
Okay, but
in my
you
life.
may.
anytime.
I had a
But,
patient in the institute also. You can have this can happen where they will say, okay, मैं इतना ही पैसा देता हूँ, या इतना मैं दूंगा ही नहीं. आप मेरी बीवी को भी रख लीजिए, बच्चे को भी रख लीजिए, मैं जा रहा हूँ. ठीक है, ऐसा ही कुछ दिनों पहले हुआ है हमारे साथ भी. In the institute also it happens. So is there any solution to this?
There is a provision in the law to
There
actually.
is, and maybe you could have a separate, people who deal with this finances, and it doesn't directly come with you. Or there may be a solution of taking the cost in batches. पहले आप इतना भर दीजिए, फिर आप इतना भर देना. अभी आपकी पेशेंट आईसीयू में गई है, तो this is the cost, and maybe that's what most of us do. I think the private practitioner also,
They
when
take some
they
advances
get
on
admitted, then the sum in percentages, and पूरा 1,00,000 रुपए एक साथ नहीं लेना है. तो maybe that could be a strategy, and let's hope कि we don't need to keep this kind of bouncers in our OPD. It's been happening in places and where there has been थोड़ा हाथापाई हो रखी है, and there has been violence against doctors. So coming to the last slide. Yes, communication is so important, and if you have any problem in your OPD setup, let's have communication with our own colleagues, so that if you need some help, like Vardha also, we have so many groups of doctors helping each other. So if you have any problem in the OPD, you should have a network amongst your colleagues where they can help you. And of course, कुछ रखे न रखे दोस्त ज़रूर रखें, कुछ रखे न रखे दोस्त ज़रूर रखें. क्या पता किस दिन वो आपके काम आएंगे. तो दोस्त रहना बहुत ज़रूरी है, आपस में हमारा कनेक्शन रहना बहुत ज़रूरी है. सो लेट अस टेक होम दिस मैसेज दैट वी कीप ऑन मीटिंग, मे बी इफ नॉट physically, then virtually also is good, but let us keep on having these communications with each other. Thank you so much. Thank you to all the panelists. Yes, ma'am.
Never blame your colleagues. 10% of the patients will rotate. In private, I'm talking. So never blame your colleagues. They will say, as you said, Madam, unke paas to aisa test hui thi. Just try and talk to them, and you will know that this patient may be a difficult one. So always keep a copy of the record. Always document. And after examining the patient, call the relatives. The husband is not there, mother is there. Call them and talk about your management and advice, and keep a copy of that.
Yes,
and unmarried girls, many times I have noticed and experienced that they don't talk in front of their mothers. So you examine them in absence of their relatives and ask them. More than 50% of them, they will say, "हाँ madam, एक दो बार तो सोए ही हैं हम लोग." सोए हैं, so that becomes a different management altogether. For PCOS, for anything, for irregular bleeding, heavy menstrual bleeding, anything. So then when you call the relatives, you document everything, and this has been discussed with the relatives and mother, and then advise this and this.
Thank you, ma'am, and thank you all the panelists.
And I think the credit of this panel goes to Dr. Rajesh Modi, because I never thought about these case scenarios. And he said, okay, कुछ तो OPD के बारे में करना है जो medico legal भी ना हो और जो normal PPH है, ऐसे कुछ scenarios भी नहीं चाहिए, कुछ तो और चाहिए. तो I think a big hand for Dr. Rajesh Modi for suggesting the concept of this OPD.
Rekha, I want to add one sentence, because here is a mixed crowd. We have seniors, we have juniors, and we have got ultra juniors also. And there is a lot of difference in the practice. Don't get too much oriented mechanically. कहीं ना कहीं human touch छूट रहा है. Most of our seniors have never faced these medico-legal problems.
Yes,
Their
agreed.
patients have never complained about repaying the bills or complications. They have full faith. We are becoming slightly mechanical. That's what my opinion is. Please, please do not lose that human touch. Our profession is not like engineering dealing with the machines. We are dealing with human emotions. And if we deal with the patients properly with the communications and with sympathy and empathy, I'm sure we will not face these problems.
Thank you. And I think the last words go to Anuradha ma'am as always. So big hand for you. Thank you.
Thank you, ma'am. I thank the moderator and all the panelists for such an engrossing and informative session. Thank you so much. Now, light is a symbol of brightness and prosperity. So to make this event a blessed one, I call upon Mr. Sameer Deni, General Manager, Indico, to proceed with further session.
दीप प्रज्वलन आपल्याकडं एक प्रथा आहे आणि आपण आता ती पार पाडूया. आज दिवस पण आपला गणपतीचा आणि महालक्ष्मीचा आहे, तर दोघांना नमन करून दीप प्रज्वलनासाठी आय वुड लाईक टू इन्व्हाइट डॉक्टर रेखा भिवापूरकर, डॉक्टर मंजुला रोहटगी, डॉक्टर जुझर विधवी सर, कोमल आपल्या टीमला सांग एस्कॉर्ट करा. डॉक्टर कॅप्टन सुमती रिधोरकर मॅम, डॉक्टर निर्मला वझे, डॉक्टर राजेश मोदी इज ऑलरेडी there.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Yeah, all the dignitaries, please just be there for 2 minutes. We'd like to felicitate on this occasion all the dignitaries also. May I request my colleagues, please, with the bouquet of flowers, can we please felicitate the dignitaries? Dr. Rekha Bhivapurkar, please. Sushant, I request our manager, Sushant. Ritesh, if you can please felicitate Dr. Manjula Rohodgi, please. Komal. Komal, may I request you to please felicitate Dr. Juzar Fidwi, sir? Atul, request you to felicitate Dr. Captain Sumati Ridwarkar, ma'am. Sushant, Dr. Nirmala Vaze, ma'am, please. I request Pushan to felicitate Dr. Rajesh Modi, and thank you, doctor, for helping us to organize this event. Thank you so much. Thanks a lot.
So we continue with the further lecture.
Our next talk is on a very queer topic which is not frequently talked of, that is vaginal aesthetics and how effective they are. And for that, we have with us Dr. Garima Srivastav, who's a founder and director at Orange Clinic, Delhi. I request Dr. Garima to please come on the dais. To chair this session, I request Dr. Rupashri Boyer, ma'am, to please come on the dais. Ma'am.
Dr. Shilpi Sood, ma'am, please chair the session.
Hello. Hello. Hi, good morning, Nagpur. I am Dr. Garima, all the way from Delhi. And I am basically into cosmetic gynecology for a couple of years now. I am faculty for American Aesthetic Association, and we have been doing various fellowship and diploma courses in India and in Dubai for around 2-3 years now. I'm really thankful to Sir and the Indigo team for having me here. They really helped me a lot because I missed my flight yesterday, and it's because of them that I'm here. Coming to this topic, the vaginal aesthetics, which is the latest buzz in the market, the fastest growing subspecialty. Is it worth all the hype? We'll just talk about this. So what actually is cosmetic gynecology slash aesthetic gynecology slash functional gynecology? So it basically, as we all know, it deals with the aesthetic appearance and overall improving the sexual functions. But actually, what is the evidence-based medicine? What are the tools in our armamentarium? Is it actually effective? When to use it and when not to use it? We are going to deal with it. Although Sir has asked me to cut down my talk, I'll try to cover it as much as possible. Can we play this, please? Okay, there is no audio, I guess. I think this is from
Siddhi's birth weight was 4.1 kilos. 8 stitches lage the, and of course I had to spend a fortune on tightening procedures.
Okay, not my words. Huh? One thing, people are spending a lot of money on these procedures. Second thing, that yes, people are now aware, even in India, that such kind of procedures do exist. And we just need to tap on it. Of course, it's from pre-COVID era, and of course, it's from Mumbai-based family. But yes, we can find the takers everywhere. So, what are the armamentarium in a toolbox? Basically, we have a few devices. Probably you all know. We have lasers. There are two types of lasers, CO2 and erbium. We have an radio frequency, HIFU, which is probably as gynecologists, we are all aware of it. It's high intensity focused ultrasound. Then we have magnetic resonance, high intensity magnetic resonance like EMSELA. We'll just discuss it in a minute. And then we have various injections, the PRPs, the fillers, the growth factors, and even the Botox. Mind you, they can all be used down there. So what are these devices and what is their basic advantage? So I'll just deal with the advantages. There is no hospitalization. There is no downtime. The patient goes back to resuming her sexual activity almost immediately. There is no bleeding. There is minimal pain. Okay, so how do they work? What's the method of action? So one thing is that they cause microablation to the vaginal mucosa, which is these small dots that we are seeing. They are basically small injuries caused by these devices, which basically activates the repair mechanism and improving the overall function. And second is by deep thermal heating. At a temperature of 63 degrees Celsius, it activates, now this is important, contraction of collagen fibers down there, which causes tightness. Then it provokes neocollagenesis, elastogenesis, neoangiogenesis, all good things. Increased fibroblast pool, and of course, increasing the thickness of epithelial layer. We did this study at our center. So this is pre-treatment, the first slide. There is atrophic vaginal mucosa with very thin epithelium. The second slide shows post-laser treatment, which has very nice, thick vaginal epithelium, which is suddenly rich in glycogen. And of course, there is increase in neovascularization in the third slide. So we all know ALMA, we have heard of it. So it's a prototype of the lasers. Hermeva is a prototype for the radio. Advantage is such a thin probe. It's similar to the width of the finger. Then comes the HIFU. So HIFU is basically secreted from this part. This is the cartridge, and it rotates on its own and gives the overall feeling of collagenesis. I'll not go into it. Then there is this EMSELA chair. So it's basically a high intensity magnetic, electromagnetic waves that are being sent, which causes supraphysiological contraction, giving it Kegel's-like effect, but probably thousands of times over. And it has no side effects. And mind you, this is FDA approved for incontinence now. Just a small slide to compare what all toolbox we have. So if we see the first two lasers, the erbium laser and the CO2 lasers, they differ depending upon their penetrability to the vaginal layer. So the vaginal layer is basically composed of epithelium, then lamina propria, fibromuscular layer, and adventitia down there. So erbium is water-loving laser. So it dissipates very quickly, and therefore it is better used for vaginal rejuvenation, the term that we are no longer supposed to say. The CO2 lasers still penetrate a bit more up to the lamina propria. So these are also good, but if you see the safety profile, probably the erbium lasers would be much better. In comparison, the radio frequencies in HIFU, they penetrate much deeper, and hence they are more effective in cystocele or probably rectocele, but with the lesser safety profile. Okay, so what evidence-based medicine do we have? So we do not have much randomized controlled trials. We have a few observational studies, but all these studies basically point out to the fact that there is positive data. Positive data in what all things? Just the shortcomings, they are very small studies. Studies are basically done on the lasers. There is no placebo, there is only one study which is basically a randomized controlled trial. Rest all are observational studies. And on other things like radio frequencies and HIFU, the studies are very less. So just in a nutshell, when to use, when not to use, so that you know. One thing is that first of all, it has to be really light or moderate SUI. Even in mixed you can use, but the stress has to be a more predominant part. We have to rule out ISD. It will not work in an intrinsic sphincter deficiency. It will only work in urethral hypermobility. It works better in dry overactive bladder than in wet. We all know what that is. And of course, patients should know that all the studies are still going on and the FDA had issued the warning, so a written informed consent is necessary. Contraindications, obviously pregnancy, malignancy, some connective tissue disorders, which will obviously obviate the need of these devices. And of course, any mesh in situ, if a TOT, TVT has been done earlier, it becomes a contraindication to, especially to the lasers. We can still do RF or HIFU, but lasers is strictly contraindicated. Genitourinary syndrome of menopause. So it's really helpful there as well. Various studies have proved it. For dryness, for dyspareunia, for recurrent urinary infection, as well as for the incontinence. Pelvic organ prolapse, it's not that useful, but maybe if your patient wants it, we can use it for stage 1 and 2, but a negative pap smear is a must. Additional uses. Now, these are some uses that we are gradually seeing. There is an increase in the vaginal microbiota. There is increase in lactobacillus, and hence there is an overall improved lubrication and reduction of BV and fungal infections. The second is it is also showing a lot of improvement in lichen sclerosis. And third is the vaginismus. We have all encountered vaginismus in our daily practice, and a single shot of Botox down there cures vaginismus for good. I'll just briefly talk about the FDA that issued the warning against using vaginal rejuvenation term as such and advising against all these energy-based devices for this. So overall, I'd just like to say that basically, when it issued this warning, it basically tried to convey that let's not misguide or mislead our patients that there is going to be a designer vagina or something like that. We need to be more practical when we are dealing with what we have. We need to know when to use these devices. The practitioner should be properly accredited. They should be properly trained. The device manufacturers should do a proper setting as to what is important and maintain a safety protocol. And of course, certain disadvantages or certain side effects are inherent to any procedures. So we just cannot say that these are totally waste. Overall, the latest consensus is that these are really useful and there is a good patient safety data. The patient satisfaction level is really high, but the clinician should know when to use it and how to use it. I'll just finish off here. Thank you.
Giving us such a beautiful insight into this topic.
Thank you, Dr. Garima. I think it was very short and sweet. In fact, we should be, it is enlightening for everybody present over here to knowing the latest, and we are getting updated these days. And in fact, good precaution has to be taken while taking such procedures. That is most important. Like negative pap smear is important. We should not ignore the basics when we are dealing with this thing. And your uptake about vaginismus treating with Botox, it's a very good input actually. We can start practicing it's very important when we are treating many of our infertility treatments, very, very important. And lastly, a training protocol has to be widely given to the
from the postgraduate levels so that they will come out with the easy application of this medicine, updated medicine in the future. Thank you so much.
I now invite Dr. Sandeep Nikhare sir for the further lecture on endoscopy in infertility. Sir is a visiting laparoscopic in multi-speciality hospital. He is a consultant laparoscopic pelvic surgeon and oncosurgeon and director at Life Springs Hospital, Nagpur.
Thank you. Good afternoon, everyone. Today I'm feeling very elated after wearing this blazer because after a gap of almost 2 years, I'm wearing this. And thanks to the team of Indoco Remedies, chairperson, and delegates for giving me this opportunity to talk in front of you about the role of endoscopy in infertility. During my post-graduation days, we used to do HSG when the patient of infertility comes to us, and then some do routine investigation like CBC, LFT, and KFT. But we used to lack this hormonal evaluation. And hysteroscopy and laparoscopy comes later. So in this era, new era, that's changed, and with the ART facility and advanced not to be done. So for decades, we are using this D&C diagnostic hysteroscopy. We proceed with the vaginoscopy with the normal saline and distension medium. We now enter into the cervical canal, and now we are watching the right corner. Now it is left cornua. Now at this point, you should examine the anterior wall, posterior wall, and both the lateral walls to find any pathology. Can you diagnose this dating of the endometrium on the hysteroscopy? Yes, we can. Now the proliferative endometrium can be seen as like in this picture, which shows light pink color to the endometrium, and the surface is smooth. The glands are like rounded, like dot-like. In the secretory endometrium, we can see the strawberry type of endometrium. The surface is irregular, and the glands are rounded. On your extreme right, there are two pictures. Can I have a pointer? So this one upper picture which shows rounded glands. This is the mid-secretory phase, and this type of endometrium is a good type of endometrium for the receptivity also and for the pregnancy outcome also. In the lower picture, you can see the this dot-like picture or like punctate-like appearance. So that is very poor endometrium as seen on the hysteroscopy. So you can date the endometrium on the hysteroscopy also. Coming on to the first etiology which can diagnose on the endometrium is the endometrial polyp, which are the localized hyperplastic overgrowth of the endometrium. 25% of the women with unexplained infertility will have endometrial polyps. It is associated with the obesity, diabetes mellitus, and PCOS. It also impairs the implantation. Now this is the video is showing the how to deal with the polyp. You can see the posterior uterine wall, there is a polyp. This polypectomy is managed with the help of normal saline as a distension media and using the rigid hysteroscopic scissors, 5 French. You can cut it with the scissor. There is a difficulty at the fundus level. Once you cut the base of the polyp, that polyp will roll in the endometrial cavity, and you can remove it by the Ohm forceps, or it can come out spontaneously also. So what is the impact? The patients who underwent polypectomy prior to IUI had an increased pregnancy rate of 51% compared to patients who did not. So polyps, and in cases of the IVF, if the polyp is smaller than 1.5 centimeter, there is no need to remove that polyp. You can directly go for the IVF or ICSI cycle as per the patient's requirement and your planning. Coming on to the uterine malformations. As you can see here, this arcuate uterus is giving the pregnancy rate of 65%, while the unicornuate, bicornuate or didelphic uterus gives the term pregnancy rate of around 40 to 45%. So the radiological differentiation of the criteria for the diagnosis of the septate uterus is depth of the intercornual myometrial should be more than 1.5 centimeter, and this angle should be less than 90 degree. While in the bicornuate uterus, on the laparoscopy, you can see the indentation. And this is the depth indentation of more than 1 centimeter that will give you the diagnosis of the bicornuate uterus. Then coming on to the management part of the hysteroscopic septoplasty. This is done with the help of rigid scissors, that is 5 French scissor under the 2.9 mm hysteroscope and 5 French hysteroscopic scissors. We are cutting on at the level of the fundus. Septum should be divided in the middle from its nadir to its base. There is a systematic delicate and shallow cut should be performed. At the end, both the ostia should be visualized. You can see a wide roomy cavity now. Always do the laparoscopy after resecting the septum to note if there is any perforation or not. Now this is a case which I did few months back. It's a world's very rare case in which till in the literature only around 60 in the double cervix and the intrauterine septum also. And just here I am showing the how does this septoplasty done with the help of resectoscope. First of all, laparoscopy showed a normal contour of the fundus. We can use the glycine as a 1.5% glycine as a distension media. You should always note the fluid deficit of around 800 to 1000 ml. Monopolar current can be used 50 to 70 watt. Nowadays, we can use the bipolar current also. Here I am cutting the base of the septum. Now you can see this another right side cavity. Don't touch or don't go near the cornua. This is the practical tip. It is better to keep the Foley's catheter on the other part of the cavity so that you cannot go lateral damage. You can prevent the lateral damage to the ureter or vascular injury during the resectoscopy. So what is the end point of resection? The hysteroscopy can move freely from one ostium to another, and when the both ostia are visualized from lower part of the cavity. If there is a intense bleeding start from the place of the resection, you should stop. If there is difficulty in achieving an end point, the patient should be assigned for control ultrasound and eventual resection. So this resectoscopy is more helpful in broad septa, while you can do the scissors resectoscope with in the thin septa. So what is the evidence says which instrument you should use? Either use this resectoscope or scissors. There is no statistical difference observed between the reproductive outcome between the women treated with the septate uterus using resectoscope or scissor. You can use either method. The postoperative management includes antibiotic for 7-8 days, estradiol valerate 2 mg TDS for 30 days, and 10 days prior progesterone 10 mg per day, so that she can bleed. You can do the HSG later on. In cases of bicornuate uterus, you can do the Strassman's metroplasty for bicornuate uterus. You have to cut the medial part of the uterus and then fix it with the or close it with the either the barb suture or the vicryl. Hysteroscopic metoplasty seems to be significantly improve the obstetric outcome in a population of women with the previous miscarriages. So this is a patient which has operated few months back, which shows a T-shaped type uterus. Although T-shaped uterus is designated as a diethyl result or a consumption, but now also you are getting T-shaped type uterus also. So DES is not the only cause for this T-shaped uterus. There are some other causes also, which we don't know. But the treatment is lateral metoplasty. Once you reach the myometrium, then the bleeding will start and you have to stop at that point. At the end, you will get a wide roomy cavity. So what is the evidence? The reproductive outcome after metoplasty shows that this abortion rate is reduced drastically from 89% to 12%, and the term delivery rate is significantly elevated from 1.5% to 74%. A paper published in this BMC journal states that hysteroscopic metoplasty contribute to improved IVF outcomes in patients with a T-shaped uterus. It's a very interesting case because this intrauterine adhesions will disturb you during the procedure also and prior to procedure also as a surgeon. In this case, started with the diagnostic hysteroscopy. See the impact of the force of the water force. These adhesions are breaking at the intercervical region, and you are now entering into the. Just see how it is breaking. Now you are at the internal os level. You are now visualizing this left ostia, and there is a band of dense adhesion in between the anterior and the posterior uterine wall. The tip to share here is that you should cut at the base of this adhesion, band of adhesion. Once you get released from that base, you can cut the apex at the apex of this band of adhesion. So technically you are removing the entire band of adhesion, and this is the end result of showing the wide roomy cavity. So women with the amenorrhea who are found to have intrauterine adhesion should be offered hysteroscopic adhesiolysis because this is likely rather than at the cervicoischemic junction. Coming on to the proximal tubal obstruction. For women with the proximal tubal obstruction, selective salpingography plus tubal catheterization or hysteroscopic tubal cannulation may be treatment options because these treatments improve the chances of pregnancy. This is the video showing the proximal tubal obstruction. On the hysteroscopy, you can see the left ostia with adhesion band, and there is a small opening in the right cornua. Once you do the methylene blue test and observe it through the laparoscope, you can see the spillage of the dye coming out through the right femoria, but there is no spillage on the left tube. So I did cornual cannulation. So what is the evidence is there is no consensus on effectiveness of hysteroscopic surgery in improving the prognosis of the subfertile women, but it definitely suggests a benefit of resection of the submucosal leiomyomas, adhesion and polyps in increasing the pregnancy rate. Is it right to send patient to costly IVF and ICSI cycles without doing cost-effective hysteroscopy? The ball is in your court. You decide. Coming on to the role of the laparoscopy in infertility. Which patient you should go for this laparoscopy? The patient with the abnormal HSG report or ultrasound report showing polyp or adhesion or any mass. Young woman with a history or symptoms of suggestive of pelvic diseases like PID or ectopic pregnancy or any prior pelvic surgery. And patient who had 3 cycles of superovulation with IUI should undergo laparoscopy, diagnostic laparoscopy, and before any IVF treatment, or if there is any evidence of any failed treatment. So what are the different surgeries we can do? It is for the ovarian surgeries like endometriosis or this polycystic ovary or ovarian cyst, tubal factors like adhesion, obstructions or distal tubal obstruction or hydrosalpinges, and uterine like myomectomy or adenomyomectomy. This is a laparoscopic view of diagnostic laparoscopy in which the anterior and the posterior part of the uterus can be seen. You can see the posterior fossa. After lifting the ovary, you can break the adhesions. These adhesions may be because of the endometriotic adhesions or because of the PID. You can see the endometriotic lesions also on the uterosacral area, which are managed with the bipolar coagulation or fulguration. So for the treatment of stage 1 and stage 2 endometriosis, laparoscopic ablation of the endometriotic enhances the fecundity by 1.6. In the cases of stage 3 and stage 4 endometriosis, operative laparoscopy instead of expectant management will give you the spontaneous pregnancy rate of almost 52 to 68% compared to the expectant treatment. So what are the options available for laparoscopic management of endometriosis? Excision, ablation of the endometriotic lesion, and excision can be done with the help of scissors, electrocoagulation or laser, and excision of the completely removal of the that endometriotic mass. This is the video showing management of ovarian endometrioma. Is a large endometrioma on the left ovarian side. Puncture it with the scissors. Do the suctioning of the entire content of the this chocolate colored fluid. You thorough saline wash so that you can see the plane of the endometriotic cyst wall. By traction and counter traction, you can remove the cyst wall. You can also inject the injection vasopressin so that it will give you create a good plane for your surgery. The bleeding point, if at all there, can be managed with the bipolar coagulation. Coming on to the tubal diseases, this is a video showing the minor tubal disease of hydrosalpinx. Although there is a hydrosalpinx, but the spill is there, so you can give a trial of 2 or 3 cycles for this, for the natural conception. And there is a pregnancy rate of almost 15 to 20% in cases of mild hydrosalpinges. But in cases of severe hydrosalpinges, like in this video, this patient was diagnosed with the ovarian cyst and on laparoscopic, there is no evidence of ovarian cyst, but a large hydrosalpinges was seen. So there is no point in conserving such tube, and you should go for salpingectomy in such cases. So in mild hydrosalpinges, the evidence is fair to recommend laparoscopic femurioplasty or neosalpingostomy, and where the tubal damage is more, then there is role for the laparoscopic salpingectomy and sending the patient for the IVF pregnancy. I have already covered this tubal obstruction. So this is another method is the femurioplasty. If the femuras are agglutinated, then you can insert the Maryland at the femuria and you can dilate it, or you can cut at the fimria, and you can create the new salpingostomy and suture that this cut tubal end to the cirrhosis of the tube, and you can get the good spillage. This is a very important slide. If you see this, if you do the salpingectomy, then the term pregnancy rate is around 25%, and the ectopic pregnancy rate is around 1.2%. In cases of this ectopic pregnancy, if you do the salpingostomy, because recently few of them us are doing salpingostomy also, the term pregnancy rate is around 30%, but the ectopic rate is significantly increased to 9%. If you do the fimbrioplasty, then the term pregnancy rate is 50%, and the ectopic pregnancy rate is around 7%. So with the reversal of sterilization or tuboplasty also, you can get the term pregnancy rate of 52%. So with the procedure like tuboplasty or fimbrioplasty or salpingo-ovariolysis, you are getting almost 50% success rate, that is term pregnancy rate. Coming on to the myomectomy part, this is the PIGO classification, and definitely this is the fibroid of numbers 0, 1 or 2 location can be managed hysteroscopically, and it's up to the surgeon's choice to manage the role of this 3, 4 and 5 location fibroid either laparoscopically. This is the picture showing the T0 type of the submucous fibroid. This is the T1 and this is T2, more than 50% invasion of the myometrium. So these fibroids can be managed hysteroscopically. So what are the indication for myomectomy? Submucosal excision can be done. Intramural more than 4 centimeter. Keep this number in your mind. Intramural diameter of fibroid of more than 4 centimeter, then you should go for the excision. So only 2 entities, intramural fibroid of more than 4 centimeter and submucosal fibroid, should be gone for laparoscopy or hysteroscopy or laparoscopic management. Subserosal fibroid, only the expectant management. This video shows the management of submucous fibroid using the resectoscope. Generally I use the 50 to 70 watt of current mode current. Start from the resection from the top to the bottom, and your direction of movement of this loop should be from above downward. The fibroid which is seen in the cavity can be removed through the Ohm forceps, or if you put the mesoporous tablet, then it can expel on its own within next 1 or 2 months. Then another is the myomectomy. We learned this technique of aquadissection from Dr. Rajesh Modi sir, and I used to go to his place for learning the techniques of aquadissection. So this is the first step is vasopressin infiltration at the myoma base. You can see how it is creating a plane for you. If you are not getting correct plane, that means either the diagnosis of the myoma is wrong, and the patient may be having some adenomyotic component. Next step is retrieval of the myoma by traction and counter traction. At the base, there is always you will get a bleeding, so you have to control it with the bipolar forceps. This is the expulsion of the fibroid. It is sutured with barb suture, or you can use the polyglactin suture as per your preference. Such large fibroid base should be sutured in 2 layers. You should always take.
So sorry for interruption.
Yeah, just last video. Yeah. And last step is morcellation. So what can be done for those patients who are malignant in young age? So you can do the fertility preservation in young women at risk of premature ovarian failure for those patients who are requiring chemotherapy or radiation therapy. And the procedure is laparoscopic ovarian transposition. It can be done at 3 positions, that is intra-abdominal paracolic gutters like this, or anterior to psoas major muscles at this location, or lower paracolic gutters. Thank you all for the chairpersons and everyone for giving me this opportunity. Thank you delegates for listening carefully.
So there's a question from the audience. How far laparoscopic drilling in thin PCOS is useful?
Yeah, this laparoscopic drilling is a controversial subject. That's why. Yeah. This is a very controversial topic. That's why I have not included those videos in this my presentation.
I think let's take this question in the next panel. It was wonderful lecture by...
Two line. Just remember 2 line. AMH more than 7.5 or 10, go for PCO drilling. If this patient is failed in ovulation induction, there is a ovaries are resistant, then go for PCO drilling unless there is no other indication. Don't do PCO drilling. And only 3 to 4 punctures, only 4 seconds, only 4 puncture, 3 to 4 puncture, depending on the size of the ovary. If it is quite bigger ovary, then you can go for 6 or 8 punctures, but 3 to 4 is the minimum. 40 watt, 4 punctures, 4 seconds.
But in lean PCOS, that is the only treatment. Ovarian drilling for lean PCOS with obese PCOS.
No, I will go with this criteria only.
Thank you, Sandeep. It was a wonderful presentation. In fact, a very good take-home messages where we have taken like removal of entire band of adhesion in hysteroscopy is very important rather than cutting the adhesions. And there are controversies in these treatment doing hysteroscopy before IVF, it is mandatory or it's take on the audience. I have my personal experience of taking hysteroscopy always before IVF because being a costly procedure, we should always look at the cavity and taking out the abnormalities out of it. It is very important, and very important is the clipping of both the tubes if we find hydrosalpinx. In fact, it is very important to have a good counseling, otherwise it affects the emotions of the patient, and that has to be taken very very boldly, this step, because it's only not the taking out the tubes or a clipping. That decision has to be taken. What is your opinion about only clipping or a salpingectomy about this? Because you mentioned salpingectomy, we can do only clipping if there is not a big hydrosalpinx. And lastly, very important point I have been noted down, like salpingectomy versus salpingostomy for ectopic management. This is a wonderful food of thought for everybody. We have to take this decision very diligently, like taking the data you have presented is a very important decision for the patient for the management of ectopic. Thank you very much.
Thank you so much.
Also premature ovarian failure, since cancers are on rise, we need to do something for the ovaries beforehand. That is a very important point. Thank you.
Thank you, Sandeep, and all the best for your new IVF center.
Thank you, sir, and thank you all the chairpersons for this beautiful session. We now move on to our next session of panel discussion, which is on PCOS, when and how to treat. And for this, we have with us our moderator, Dr. Apurva Pallam Reddy, who is a practicing gynecologist and infertility specialist working in Bangalore for the past 10 years. To chair this session, we have with us our list of panelists, Dr. Dipali Shukla ma'am, who is director at Shukla Test Tube Baby Center, Akola, and senior consultant obstetrician and gynecologist. Next we have is Dr. Sushma Deshmukh ma'am. Madam is consultant gynecologist and obstetrician, director at Central India Test Tube Center, head of OBGY department, Getwell Super Speciality Hospital. Dr. Paresh Gandecha sir, Dr. Sangeeta Tajpuria ma'am, Dr. Parul Sauji, who is an infertility specialist and executive director at Omega Hospitals. I request all the chairpersons to please come on the dais. Sorry, panelists.
Good afternoon, everyone. I'm Dr. Apurva Pilamreddy from Bangalore. Thank you so much for all the panelists to be here today, and thank you, Dr. Modi, for inviting me to the beautiful city of Nagpur. It's my first time here, and lovely weather, and it's really great to finally see people and be on the stage and have a discussion. So today we will be talking about PCOS, and I think PCOS is so common that we cannot have one single conference without actually discussing about it, be it in a gynecological forum, be it in a laparoscopic forum, or be it at a fertility forum. The three major divisions of even, and for that matter, even in an ultrasound forum, I think, we cannot have an event or a conference without discussing about PCOS because it is that common. If anyone is, tech savvy, and if you're on the social medias, you have so many PCOS forums and, people giving away information about what you need to do and, how you need to do regarding PCO management and, a whole lot of other things. So yes, it is that common because PCOS still, despite all the advancements we have, is still an enigma. We don't know what actually causes it, and we don't know, there is no one good way or one right way of treating it. In the previous conversation, Madam had said that, okay, drilling is the only treatment for lean PCOS, and, she's right from her own perspective. And, I will still be right from my own perspective if I say that, okay, drilling shouldn't be done. That's the whole point about PCOS, and I hope the panelists are at loggerheads with all the conversations we have, and so that we should be able to have a good discussion. And in fact, I'm not sure how many of you know, there are so many conferences before COVID that used to happen exclusively on PCOS, and we have a PCOS Society of India also that's actually started by Dr. Durusha ma'am. And again, as I said, that's because PCOS affects all spectrums of life. You talk about adolescence, you talk about reproductive age group, you talk about perimenopausal. Every single woman in their spectrum of life is affected by the symptoms of PCOS. And today we will try and exclusively focus on the fertility aspect of it. I'm not going to talk about the adolescent acne, hair fall, and so on and so forth, or the endometrial hyperplasia and risk of cancers, or the risk of cholesterol-related issues with PCOS. We'll exclusively talk about the fertility. So these are the 5 topics that we will be discussing, and role of ART. Most of the points that I have placed today are from the draft that has been given combinedly by ASRM and ESHRE, which is called as the International Evidence-Based Guideline for Assessment of PCOS. That's released in 2018, and that's the latest reference. So to start off with, our first case scenario, we will go through the journey of Miss Lisa. So we will be going through her journey at different stages of her life, who is having PCOS, and how we are going to treat her in those parameters. So 25-year-old Lisa, she's been married just for a year. Her cycles are irregular, about 45 to 50 days. Sometimes she bleeds on withdrawal, and sometimes it comes spontaneously. Her ultrasound showed 14 antral follicles, and bilateral ovarian volume is around 11. She does not have any clinical features of PCOS, and she's definitely not anxious to conceive. So she's just come to you with a ultrasound report that shows PCOS. I think this is very common these days, wherein they come to us with PCOS. So how are you going to counsel her? She is concerned that PCOS is there. Madam, I think we will start with you. She's concerned that she has PCOS, and she's heard from entire family wherein say you have PCOS, so you can't get pregnant, and so on and so forth. So, shoot.
Hello. First of all, I will counsel her about the menstrual irregularity is not much. She's having menses at the interval of 30 to 40 days. I will like to know her weight, whether she is obese or thin. Only sonographic finding of polycystic ovaries, that to 11 cc. And if she is a normal weight person, then it is not going to have any problem because she is not having any hyperandrogenic features. I will counsel her to have regular exercise. I will ask about the family history of diabetes, and I will get her normal hormonal profile and oral GT glucose challenge test, and just counsel her on the diet and exercise management, and not to worry because she is not having any major androgenic side effect. And if she get cycles at the interval of 30 to 40 days with normal weight, she can she can conceive normally also, because she is not trying at present. She is not trying for the pregnancy. Just exercise, folic acid supplements, and if there are any hormonal problems, then we can correct it.
Perfect. Anything else that you would want to add? 3-4 points that you're going to tell.
First of all, I would like to ask you for what purpose she has come.
She's just come with an ultrasound report.
Why she did the ultrasound?
She just got it because her periods were irregular. Okay. And someone has told her to get an ultrasound. She's got an ultrasound that says PCOS. Okay. So she's come to you with the report.
Then I would like to ask her about her profession also, whether she is an IT profession or where she's working, where the husband and they are working at the same place.
Sure. And that's an exceptionally good point, because I come from the city of Bangalore. There is a typical profile for PCO patients. They have come from some other city, they're staying in a PG, they're doing night shifts, and they've been stressed. These 3 factors, they'll nod their head to for sure.
And that is very important factor, because nowadays lot of girls coming like this. So that's why it is very important to ask their professional history. Secondly, if she is not keen on conceiving, because as she is 25 and these people, if she is working, they may not be keen about conceiving also, but still we should counsel her. I will call her husband, and I will also ask her to test him, because it is very important to, because oligospermia is very common in such people also. So it is very important. We have to give the combined thought about it, and then counseling is very important, as Dr. Deepali suggested, like diet and the exercise, which is very important. We have to ask her, because always I ask PCOS patient about their lifestyle, because many times they are not getting up earlier, they are getting very late to bed. So that is also very important for the proper lifestyle management. Sure. That is very important.
Dr. Paresh, anything to add?
The only thing is lifestyle management. That is what is required out here. Because
so from a medical perspective, is there anything else that you would want to kind of generally add? See, let's forget about the panel discussion, or, we'll talk in a practical terms. What are the things that you would kind of tell this patient?
If she is more anxious about getting pregnancy and somebody has told her that because of PCOS she is not going to get pregnant, first thing I would like to tell her is that in her case I feel the PCOS is little overdiagnosed, because of ultrasound criteria is only not sufficient to diagnose her
Absolutely.
as a PCOS.
Absolutely.
So if she insists, we can get her hormonal profile done, fasting sugar and AMH, FSH, LH, prolactin if she wants. And if everything is all right, we can tell her that you can go for a natural pregnancy whenever you want.
Sure.
And if you are not able to conceive spontaneously with 1 year of unprotected intercourse after planning, then we are there to help you out.
Right.
And PCOS is not an enigmatic disease where you have to be worried about pregnancy that much.
Right.
Because even if you are not getting pregnancy after 1 year of unprotected intercourse after planning, we can actually give simple ovulation induction and most of them become pregnant.
Sure.
And first thing I would like to tell her that I think this patient is overdiagnosed PCOS rather than actual PCOS.
So I think that's an excellent point. We need to understand that ultrasound, whenever you're getting done, it has to be a transvaginal ultrasound. Anyone who's diagnosing a PCOS on a transabdominal ultrasound is not a great radiologist, and we should never be considering that report. It has to always be a transvaginal ultrasound alone. You cannot make a diagnosis of PCOS from an ultrasound criteria if you're doing a abdominal ultrasound alone. Second thing is, whenever we have patients like this, there are just 3 points that you need to discuss. That right now she is getting her periods at 30 to 40 days, well and good. But eventually in the future, there is a possibility that she might not get her periods for 60 days or 90 days or 3 months also. So just tell her that if she is not concerned about pregnancy, she needs to ensure withdrawal bleeding at least once in 2 months. As simple as that. She does not need to come to you also. Second factor, of course, as the panelists have mentioned, we need to look at her weight. In case if we feel her weight is on the higher side, we need to tell her to reduce it and then consider placing her on adjuvants in order to feel, in case if we feel that the weight loss is difficult. 2, if she's a little on the leaner side, then let her know that she shouldn't be gaining weight in the next 1 year, because whenever you have PCOS, you have abnormal metabolic profile and you do have a tendency to gain weight. So she needs to check. My simple measure of telling patients how you need to prevent weight gain is check your weight every single day. That's the thing. If you are checking your weight every single day, you will not wake up one day realizing you have gained 10 kgs, and or you can't measure how much weight you're gaining just by how tight your blouses are getting or how tight your clothes are becoming. If you check your weight every day, you will still be able to control it. And third important thing, whenever she is planning for pregnancy, it is important that she comes to you, because 80% of women with PCOS are anovulatory. So you waiting for another 1 more year, trying naturally and then kind of coming is almost a year's time lost. So women who have been diagnosed with PCOS should come down to a gynecologist whenever they are planning for pregnancy in order to check if they have an ovulatory or an anovulatory cycle. Even if you have regular periods, you have a 30% probability of having anovulation. So, which is why whenever women with PCOS are planning for pregnancy, it definitely makes sense that they come down from an early time and then start looking at it. Also quickly remember that PCOS is a diagnosis of exclusion. You need to get their thyroid profiles, prolactin, and ensure that their sugar profiles are normal before we go ahead and just label them. Now, the same patient, she has come back to you at 27 years. She has been married for 3 years now. She has taken your diet advice. Her cycles have become pretty regular. Her antral follicle count is still the same. She still does not have any features of hyperandrogenism. And now she wants to get pregnant. So how do we go ahead and manage her?
We can get her hormonal profile done once she's there with us. We can get her AMH done.
So let's take AMH. What are you achieving by getting an AMH?
How much the...
Purva is fine. Yes.
How much the PCO is. So I think AMH would give us a pretty good idea about that.
We already know that through the ultrasound, right? We know that
only ultrasound is not a criteria for us to diagnose her as PCO, first of all. And second of all, she's married for 3 years now. She's 27. So on the basis of AMH, we can probably think that we can just call her for just seeing whether she's having ovulation or not. Or shall we give her any planned relation cycles or not? So we can just see the AMH for that patient. We can get her hormonal assays.
So let us say her AMH is 5 and let us say her AMH is 9. How is your treatment going to change?
Ma'am, if her AMH is 5, we can call her and we can see whether she's ovulating or not. But if her AMH is 9, then in those cases, we can probably think of giving her ovulation induction drugs.
So this is one thing you need to remember. Whenever you are getting any tests done, करने के लिए तो 100 टेस्ट कर सकते हैं, FSH, LH, E2, P4, AMH, मतलब भर भर के कर सकते हैं. एक test, if you're getting it done, is it going to change your line of management? That is your first question. If it's not going to change your line of management, there is no need to get the test done. AMH is definitely an excellent test for PCOS in two conditions. Someone who's not married and you want to make a diagnosis of PCOS, you can't do a transvaginal scan. You're getting an AMH done. It is around 9, 10, whatever it is. You know that you will be able to predict a diagnosis of PCOS. Second condition is when if let us say you have given her medications for ovulation induction and she is not responding, tablets दे दिया, adjuvants दे दिया, respond नहीं कर रही है, then you get an AMH done if you are considering an ovarian drilling.
Laparoscopy, like we are following a criteria at our center that if the AMH is more than 6, then probably we will be doing ovarian drilling for her. If it is less than 6, then we wouldn't be doing.
Absolutely. So it is not that everyone who has an AMH of 8 or 9 should undergo an ovarian drilling. It is just that before you go ahead and do a drilling, sometimes you feel that the patient is very resistant. But if the AMH levels are only about 5 or 5.5, doing a drilling for her doesn't make sense and it's not going to help you in ovulation. So the role of AMH in a PCO patient probably is one, to kind of make a diagnosis, two, to kind of understand if the drilling needs to be done or not. And yes, Amog. So LH actually does not have any role for your ovarian drilling because it's your ASD levels. Your androstenedione is the androgen that is being secreted by your ovarian stroma. LH is being secreted by your pituitary. Okay, testosterone is being secreted by your adrenalines. Androstenedione is the one that is being secreted by your ovarian stroma. So if you have elevated LH, or if you have elevated testosterone, nobody cares. Only if you have elevated androstenedione, because when you're doing a drilling, you are puncturing the ovarian stroma, right? So only if your ovarian androgen levels are elevated, it would kind of make sense for you to do an ovarian drilling, and that is when it's going to give you better results. You will have spontaneous ovulation, so on and so forth. I will get back to the ovarian androgen levels in a bit. Madam, so AMH, definitely there is a role in PCOS, exceptionally good. And more importantly, sometimes, patients are labeled as PCO and वो सालों साल ऐसे ही label लेके चलते हैं. जब तक हमारे पास आ जाते हैं, तब तक उनका poor ovarian reserve भी हो चुका होगा. And that is when you need to get a AMH done and tell that कि भाई, ovarian reserve अभी खत्म हो चुका है, PCOS अब बचा नहीं है.
Many a times the patients do come, probably when they're 25, 26, they get these scans, especially the IT people. They get the scans in their PCO. But it's like 34, 35, when they're planning pregnancy, they still have that in their mind that they're PCO.
Exactly.
And that is when the ovarian reserve has gone dramatically low.
Absolutely. मतलब office का health check में PCO आ गया 10 साल पहले. Ma'am, so AMH definitely a role in certain situations. What other investigations would you want to? Now she's planning for pregnancy. So she's come to you. How do we proceed?
She is a case of PCO. Along with her, I would like to assess her husband.
Exceptionally good. Everybody needs to take a moment for this and actually have to clap for madam and say that this is what we need to do. Please go ahead, ma'am.
She has come to you this time for conception. So as you have the impression of her that she is PCO, she is not only the one who has to be evaluated. As a couple, we have to assess both semen analysis and as well as tubal factor should also be taken into consideration.
It's almost like a ma'am has seen my slides only right now. But yeah, I have not shared one single question also with any of the panelists. It's their regular question that's related to the practice. Go ahead, ma'am.
So, and then we will be going with now how we have to do her tubal assessment. Considering her young age, now there is two options. Non-invasive, or you can say OPD procedure, and then the invasive, that is chromoperturbation. You have to assess the patient anxiousness, her cooperation, and the budget.
Absolutely.
In these cases, what we can also do is that we get an AMH done. If it is more than 6, then we would probably take her up for laparoscopy.
No,
you are having your own lab setup.
No, actually, if she is ovulating,
Yeah, go
then I don't think just by seeing the AMH.
Absolutely. You know, I almost feel कि that हर किसी का budding laparoscopic surgeons का मतलब initial laparoscopy सीखने के लिए drilling एक procedure है कि मतलब drilling अभी कर लेंगे. Sir, you go back on the slide. Yes, sir. One more slide. Yes. The cycle fun. Yeah. Exactly. Exactly. So cycle. So agreed that if you're having a regular cycle, you have higher probability of having ovulatory cycles, but not all the 12 months are going to be ovulatory. There is a possibility that अगर 12 महीने हैं, उसमें 2 महीने जब आपने follicular scan किया, उसी महीना ovulation हो गया और बाकी के 10 महीने नहीं हो रहे हैं, despite being normal and despite being regular. So yes, it is important. What I call this is as a fertility check. So whenever you have, anyone with respect to PCOS or a couple who is kind of coming to you for pregnancy, go ahead and get a fertility check where you are evaluating. Of course, uterus तो आपका, regular pelvic scan में ही आ जाता है. See if she is ovulatory or not. Check for the fallopian tubes, and more importantly, as Madam has said, ensure that you're getting a semen analysis also done. Because you don't want to give the patients 6 महीने of ovulation induction and 6 महीने के बाद realize किया कि एक side तो tube block है, या फिर 1 साल के बाद realize किया husband तो azoospermic है. So these are all very simple and non-invasive tests. So if the patient is ovulatory we will reach with respect to the ovulation part of it. So this is again another criteria which is really good for us in evaluating how severely morbid the PCOS is going to be. So we know that according to Rotogram's criteria, we have 3 things: oligomenorrhea or amenorrhea, hyperandrogenism, and PCOS on the ultrasound ka features. So if the patient is having all the 3 parameters, then isko treat karne mein हमारी difficulty होने वाली है. Ovulatory PCOS, as Sir has mentioned, if it is possible that the patient is having PCOS morphology on the ultrasound, is showing evidence of hyperandrogenism, पर उनका cycles regular है, तो इनको treat करने में थोड़ी कम मुश्किल होने वाली है. So these are the regular things that we need to understand in order to figure out how difficult or easy it is going to be for us for monitoring these patients and managing these patients. So yes, tubal testing is definitely something that we need to go ahead and plan. So now we've gone ahead, उनका fertility evaluation कर लिया, sperm parameters भी ठीक है, एक develop fallopian tubes भी ठीक है, bleeding भी महीना हो रहा है, but it is oligomenorrhea. So now we decide that we want to go ahead and do ovulation induction. What will be the first choice of ovulation induction, ma'am?
I will start her with oral ovulation induction drugs like letrozole. I will get her scan done on day 2 or day 3, baseline scan.
Perfect.
Rule out ovarian cyst or endometrial thickness. And then I will start with tablet letrozole, 2.5 milligram 2 times a day for 5 days.
Fantastic. So I want the audience, everybody, to take a moment of pause. Letrozole is the drug of choice for ovulation induction for all women with PCOS. I have stopped using clomiphene citrate for a long time. Great drug. I hope Indoco doesn't have any product of clomiphene citrate, but letrozole is the drug of choice for women with PCOS. Please, ma'am.
Then from day 10, I will start her ovulation monitoring, whether she is ovulating or not. And if she is ovulating, then I will ask her to have a natural intercourse. And this, I can repeat her for 2 to 3 cycles.
Perfect. Madam.
Because letrozole is the drug of choice in the same dose.
I like it when my panelists agree with each other.
And,
Please go ahead.
Can start with and I can see whether she's ovulating or not. Even though she is having cycles regular, I must see with the letrozole she is ovulating or not.
Absolutely. That is the most important thing. It's not that your job is going to be done once you give her 5 mg of letrozole for 5 days. You have to document at least one cycle of follicular growth. Only then will you be able to tell that, acha, theek hai, you need to tell me how long we have. Okay. So only then will we be able to kind of understand if she is responding to your letrozole or not. So at least one cycle of follicular monitoring.
So endometrium has to be seen whether it is properly developing along with the follicle.
Yes.
So along with that, when the follicle is around 18-20, I will give injection SCG because she will need it. And accordingly, I will give luteal support also because already 3 years already there.
Sure.
Is trying for that.
Absolutely.
So we can plan accordingly. 2 to 3 cycles we can plan.
Great.
And accordingly, if suppose she doesn't conceive again, then we have to plan further. We have to, already we have checked her semen analysis, that parameter is normal, tubal function is normal. Then again, we can counsel her regardingly. Now these are the various strategies are there. We can try IO also.
Sure.
Along with the adding gonadotrophins. Accordingly, we can, but we have to counsel accordingly. How
Right.
much, we have to see her pocket also. Accordingly, we can plan.
Right. Dr. Paresh, how long do you think you will wait to see follicular growth? 12th day देख लिया सारे follicles 12 mm 10 mm ऐसे हैं अभी क्या करेंगे?
I will like to scan her on day 8. If I am giving letrozole from day 2nd, day 8 should be the first scan. If I cannot see any at least 2 to 3 follicles of more than 12 to 13 millimeter, then I would like to add on gonadotropins to these kind of a cycle. Because if they are not, follicles are already recruited, but they are not growing.
See,
You have to add
remember,
on.
this is the first cycle that you are giving her letrozole.
Doesn't matter, even if it is a first cycle or a last cycle, if she is not responding in this cycle, she might respond in the next cycle. You can monitor again.
Sure.
But from this cycle onwards, if it is she is not getting stimulated, already follicles are recruited, but they are not growing, just to add on, adding a gonadotropin will not harm anything. It will cost few bucks, but then the cycle cancellation rate is very low for that.
Yes, ma'am. No, now there is a fact. Yes.
No, for the first cycle, I think I will not add gonadotrophins.
Yes.
I will counsel her.
Yes.
And I will see the follicular growth till the day 21 because many times we do see the follicle starts growing after some period.
Yes.
So, and we many times we leave the cycle and the patient comes with the pregnancy. So that's why we have to counsel it accordingly. The cycle is like this and we are going to wait for this cycle. And if it is like this, we can increase the dose in next cycle. Because for the first time we are starting, I think we can start with the oral ovulation.
So adding gonadotrophins is a great strategy in order to increase pregnancy. Like if I get a patient who's already tried a couple of cycles of letrozole in the past and she's not got pregnant and now she's coming to me, I would definitely not waste time in giving another cycle of letrozole and trying. I would definitely add gonadotrophins from the 8th or 9th day as Dr. Paresh has mentioned. But if she's coming to me for the first time, then it definitely makes sense to wait at least for the 18th day because I think all of us have seen in our practices wherein patients have ovulated a little later, towards the 18th day or 19th day of the period also. As long as they are ovulating, it is still all right. You don't need to be very aggressive in going ahead and starting gonadotrophins because gonadotrophins require monitoring every month. इस महीना उसका ओवुलेशन अगर हो गया है, I can't tell her कि that अच्छा ठीक है, next महीने से 5 days letrozole ले लो और 3 दिन का gonadotrophin ले लो और फिर उसके बाद naturally try करो. I can't do that. I have to monitor her every month, which is going to be taxing. Because आप gonadotrophins दो या फिर letrozole दो, ovulation जब आपका होगा, natural pregnancy का possibility is only 5%. So unless you're going for an IUI, it doesn't make sense in monitoring cycle. Madam.
No, in this case, if I will start letrozole from day 3 to day 7, then I will call her on day 8. If I will not see even a single follicle of 10 millimeter, I will repeat my 5 days course of letrozole from day 8 onwards. It will be an extended letrozole protocol. And then after from day 8 to day 12, I will assess her. And if I will get 12 millimeter on day 12 or day 13, that means this induction has recruited the active follicle. And then I will ovulation in the study I will be doing, and then maybe at day 18 or day 19, I will get the dominant follicle. So rather than adding gonadotropins, I will extend the letrozole protocol for more than 5 days.
Usually what we are doing is that we give letrozole to the patient, like ma'am has said, that 2.5 milligram twice a day for 5 days. And then we are calling them on day 12 to assess whether the follicle is there or not, because usually by day 12, we do get a follicle which is at least 12 to 13 millimeters. And if not, then we are calling them on day 18 again. And such 3 cycles for a patient like this, we are at least giving 3 cycles and doing the monitoring. If not, then we are adding the gonadotropin.
I totally agree with doctor that way. That is exactly how we are practicing also. Yes, there have been some studies about extended use of letrozole, or increasing the dose of letrozole to even 7.5 mg or 10 mg, but none of those studies have really been supportive in improving it. So I think in this point is where your adjuvants will kind of come into play, wherein you feel that ovulation is kind of not happening immediately on the 12th day or 14th day of cycle. Adding adjuvants will kind of enhance your ovarian response and kind of increase the possibility of making sure the ovulation happens reasonably or fairly on time. So, quick question, do you do insulin sensitive tests before starting adjuvants? Simple answer, yes or no?
No. But I do give empirical insulin sensitizing agent according to the patient. Either it is myoinositol chironositol combination, or it is myoinositol metformin, or it is metformin. These three
BMI is more than 25. Probably we can add metformin to that.
Great. So, we usually follow certain criteria wherein insulin sensitizing tests are not really as reliable as we would like them to be. So the patient could have really bad insulin sensitivity and still their IR tests or your HOMA test might come negative. So clinical features are some parameters which we consider as an indication to start. One, as Madam has mentioned, with respect to elevated BMI. Difficulty in losing weight. You see that they are having bad acanthosis nigrans. Failure to respond to ovulation-inducing agents. These are definitely certain parameters wherein we would start insulin sensitizing agents, either in the form of metformin or myoinositol beforehand in order to reduce the incidence. So, yeah, now she's now become fat somehow, Papa. She's 28 years now, 4 years married life. BMI has become 34. She's an ovulatory with clomiphene citrate also. We have tried letrozole also. We have tried. We've put her on adjuvants also. And her AMH is 8. Now, madam. So what do we do?
We'll insist on weight reduction and proper, she is still 28 years. We can give time for her weight reduction and exercise. And we will add gonadotropins after she loses 5 to 10% of her weight. Then we'll add with the gonadotropins. We will try with gonadotropin. If she ovulate with gonadotropins for 2 to 3 cycles, then we add with the IUI. And if she is not ovulating with gonadotropins also, then we'll go for laparoscopic ovarian drilling.
Madam?
If she has gained weight now, and we have to see the other clinical features also. If they are like that, I would like to add the metformin also along with that. And again, I will try for ovulation. Suppose if already we have tried with the letrozole and clomiphene, I think 200 is a very higher dose. We are not giving 200 dose.
Right.
And then we can add the gonadotropins. You can add the cycle because gonadotropins for a PCOS, it's a really tough job. Many times they may suddenly they can hyper respond, or many times we may not get the response. They are many times resistant for stimulation. So we have to keep in that mind because AMH is 8. So apart from, as Dr. Dipali suggested, weight reduction, counseling, which is very required for such patients. And then we have to add the like that. Suppose we have given the letrozole along with the 3 doses of gonadotropins. And we can just check
So let us say for this patient, will all of you agree that the only 2 possibilities that we have is either doing a laparoscopic drilling or starting गोनाडोट्रोफिन्स, बस यही दोनों ऑप्शंस है.
Still, I will not do the laparoscopic ovarian drilling.
परेश.
Again to controversy. I will go and do laparoscopy drilling for her first.
Same
And
here.
after that, the next cycle, we'll start a stimulation with letrozole and add on gonadotropin as I suggested.
Sure, sure. Madam, any?
If you are doing laparoscopic drilling, I don't think in the very next cycle she require anything. Drilling itself would help in her ovulating, or else you have to, if we start on gonadotropins, in this case, assuming to be very resistant to oral ovulagens, I would like to have a chronic low dose protocol with recombinant FSH in this case.
Okay. So, how much does a laparoscopy cost in Nagpur? 40,000 plus medicine?
22,000 plus medicine.
So, लगभग एक 40,000 में आपका, हाँ ठीक है, so एक 40,000 में आपका laparoscopic ovarian drilling हो जाएगा. How much do gonadotrophins cost? 1500, 150 units का. HP, HMG 150 units, pre-filled syringe 1500. IUI भी कर लो, 5,000, 6,000 का. 3-4 साइकिल आपका IUI with gonadotrophins हो जाएंगे ना. पेशेंट तो आपको प्रेगनेंसी के लिए आ रही है. Why do you want to do drilling? Why can't you do one cycle of gonadotrophins, see if she is able to respond with that, and what if she gets pregnant in that cycle? Why do you want to put the patient through GA, do a drilling, increase the risk of having a premature ovarian failure in the future, and everything else? Yes or, I mean, am I making sense? Without doing one cycle of, forget about theory.
Theoretically, you are correct, but in the practical scenario, in a practical scenario, ovarian drilling will give
sir,
its
abhi aap
effect for a
mujhe-
couple of years. So you cannot count it in 4 IUI cycles. The cost is to be divided in 2 years.
So आप मुझे गारंटी देंगे laparoscopic ovarian drilling के
Guarantee
बाद?
तो मेरी आप
Gonadotropins,
I
she would
agree with
have
you,
that,
madam.
ovulation. She'll have that follicle which is going to be dominant.
फिर उसके बाद कर दो ना.
Ma'am, as it is a success rate of IUI is
आपके
15 to
4 IUI का
20%.
cost हो गया.
That too, it is a cumulative success rate.
One cycle.
Cumulative success rate is around 15 to 20%, which means that 4 cycles, which is almost 40. And I don't think it costs 40. I mean, we are charging 22 plus 2 to 3,000 of medicine. That is 25,000. I think that would be a
Correct.
good option.
Absolutely correct. I
let
do
us say-
agree with you 100%.
Let us say, I will give you an option. That there is, I'm not telling you that drilling is bad. I have done drilling for patients myself.
I'm sorry for the interruption, but we are really running behind the schedule. So
5 minutes? Sure. 5 minutes, okay. So what I am trying to tell is, I am not against drilling. You know, I have also done laparoscopic drilling for a lot of patients. I am saying that there is no harm in trying one cycle of gonadotropin induction and seeing if it works. आपके लिए अगर कोई आके बोलेगा कि that आपका एक option है, injections के साथ try करके देख सकते हैं, या फिर surgery करना पड़े. For yourself, या your own family, or your own sisters, or you know this thing, would you kind of want to give yourself at least an option wherein you're trying something which is non-invasive?
Apurva ma'am, we can actually give an option of 2 cycles of IUI with gonadotropins.
Which is
We can.
all I am saying. I am not saying that
At the age of 34, she has
she's
an
not
image.
34, she's 20. Her BMI is 34. Her BMI is 34.
Even at 28, if the AMH is 8, I do not think that she will land up in premature ovarian.
You cannot decide that. You cannot decide that. You cannot say, yes, Amog. Amog, if you don't support me, I'm not going. Yes.
But ma'am, do we not say this that we can try IUI for 4 cycles?
मैं बोल रही हूँ
How many cycles would we want to give her with gonadotropins? How many?
Yes, Amog. Yes.
Yes.
Yes. Correct. Absolutely.
Amok, there are two advantages of doing laparoscopy. You can rule out endometrial tuberculosis and you can rule out endometriosis
वो
both.
तो हम
You
non-invasive
can do a
testing
tubal
अगर
patency test
आपका
also.
menstrual, yeah, do a menstrual blood.
Ultrasound.
Yeah, but still I feel that laparoscopic drilling should not be done in this patient.
एक महीने
Because
देख
we
लो
can
यार,
try.
एक महीना
We
देख
can
लो.
give at least two trials,
Patients have conceived after drilling, with respect to after doing a LOD. I'm not against it. I'm just saying don't make LOD as your first option, because as a fertility specialist, 30% of my premature ovarian failure patients have been because of LOD. There are fantastic lap surgeons. I'm not denying all of that, but not all of them are up to that level. If someone who is kind of starting their career or initiating it and does not have the right kind of electrocautery with them, and if you are frying up the ovaries of a patient,
Apurva, for this patient, your first line of treatment is already finished.
she has taken adjuvants, she has taken
Not gonadotropin.
It was also.
ओवुलेट नहीं हुआ है तभी तो गोनाडोट्रोफिन शुरू करेंगे ना. एक डायरेक्टली एक पेशेंट आ जाएगी तो उसको डायरेक्टली हम गोनाडोट्रोफिन नहीं शुरू करेंगे.
You mean to summarize it that first line of treatment is ovulation induction with oral ovulation.
Oral and
Second line
injectable.
is
This
with
patient, she is
gonadotropin, and
not-
third line should be laparoscopic
Yes.
ovarian. That is a correct.
According to the guidelines,
I agree with her
laparoscopy is
now.
also the second line of management for these patients.
I'll come to that. So, so to kind of just quickly run through it, let us say the only 2 points that I think if you're going for an IVF for a patient, I think all of us would agree that the best stimulation or the ANTAC that we will be giving for them would be a GnRH antagonist cycle. That is pretty clear. We are not using an agonist cycle anymore because giving an agonist trigger is going to reduce the risk of OHSs. So, wrapping up in 3 minutes. Quickly, would you be taking a PCO patient for a donor? Would you be taking a PCO patient for, like, when you're screening patients and when you have donors who come down to you, if the donor is having PCOS, would you accept her as a donor?
If no choice, then I will accept her.
If you have a choice.
I will accept because we.
Everybody is very ecstatic to kind of see a PCO donor. Everybody's like, "Bas, matlab, तेरे पे खुशी की खुशी आ जाती है."
But according to guidelines, you cannot sharing and it is not recommended nowadays.
Dr.
Legal guidelines are there now, and they are saying that you cannot.
Yes, Amog. Yes, madam. Nishit.
Okay.
Finish, ma'am.
Basically, what you are saying that the PCO, that you are just placing her like a donor. Okay, but you think your center should be like that?
No. I am saying that we need egg donors. So we call in 3-4 girls. The 3-4 girls who have come as egg donors, one of them is having PCO. The other one is not having PCO. So will you take the women with PCO as donor? Amog.
Yeah, so basically, if you're taking a PCO as a donor, the PCO itself have immature eggs. Even with a good stimulation, if you get around 40 eggs, 30% of them are immature or M1 oocyte. So when the eggs itself are defective and you're using it for an infertility patient, there is no logic in using a PCO patient as a donor for patients already suffering from infertility. It is better to
I
use
would like to say a fertile PCOS donor. I would go for it.
Of course, we have
Yeah,
taken
the
it as a
criteria
donor.
is
She's fertile.
fertile.
She has
Has
her
to
own
be fertile.
child.
That's a criteria for a donor.
Of course.
But we will do the pre-treatment of the donor also, so that we can get good number and good quality of oocytes.
How many patients how many donors do you know get pre-treatment, or how many patients or donors that
Folic acid भी नहीं लेते हैं, मतलब शुरू में जाते हैं day 2 से.
One thing I understand is if you're screening for a donor, she has to be Paris. She has to have at least her own one child.
A donor
So
has
if
to
she's a fertile PCOS, there is no risk in taking her oocytes.
Absolutely. But we should be able to monitor wherever the agency which she's come from. She should be monitored properly that there is no OHSs in her. That's what is important.
Antagonist.
That is what is important for every donor.
Donor, as Amog has rightly mentioned, it is true that you have a higher incidence of developing immature oocytes. There are altered oocytes, so on and so forth. But it is also seen that women with PCOS have almost 3 to 4, at least minimum of oocytes higher than a normal patient, which will overall in a cumulative manner increase their pregnancy rates. So, and that is backed up by a couple of studies also. So yes, if the patient is having PCO, only on an ultrasound morphology, there is no contraindication to take it. But if you remember the previous things that I told you, if the patient is having severe hyperandrogenism, if she is having acanthosis nigrans, in case if her sugar levels are altered, if her cholesterol levels are varied, then you have a higher probability of the oocyte also being abnormal. So those patients probably are not going to be the ideal candidate. Yes, Amog. So this is my last slide, and yeah.
One more point. If the new ART bill comes into the picture,
So that
you cannot use more than
we can't take normal risks. So the new ART bill says that we can extract only about 6 to 8 eggs from. That's it.
And that too, it has to be a frozen oocyte, and it should not be a fresh donor oocyte. It has to be a donor oocyte frozen at least for 3 to 6 months.
That's another discussion for an entire day. But yes, to kind of conclude, once we make a diagnosis of PCOS according to the Rotterdam criteria, we need to get a follicular scan done in order to see if the patient is ovulating or not. In case if the patient is not ovulating based on their BMI, lifestyle changes, you go ahead and advise them accordingly. And if they still don't ovulate, that is when we go ahead and use letrozole or oral ovulation inducing agents for getting ovulation done. And yes, we can add adjuvant therapy in the form of myoinositol and decarinositol, which are much more accepted and have less side effects as compared to metformin alone. If they don't ovulate, the second line of therapy can be either using gonadotrophins or laparoscopic ovarian dilling. Both of them are given as the second line of therapy. And yes, it's absolutely your choice. I will be more than happy if of all these, elite guests, even if one person chooses to try one cycle of gonadotrophin therapy before they go ahead and do a laparoscopic drilling. And of course, despite all these parameters, in case things don't work out, or for any other non-PCO related parameters, you can go ahead and do an IVF, but just ensure you're doing a ANTAC cycle. Thank you so much, everyone.
Thank you, ma'am.
So much
It was
for
lovely.
the entire panelist discussion. Yes, we have no hard feelings.
Thank you.
Thank you.
I thank the moderator and all the panelists for such an engrossing and gripping session. We now move on to our last session of the day, which is a talk on the wow and the oops moment in laparoscopy by none other than Dr. Rajesh Modi sir, the face behind today's conference. And to chair this session, Dr. Smita Devle, madam. Madam is a senior obstetrician and gynecologist working in Nagpur. I request, गए madam भी.
I will request Vidvi sir to please chair this session.
Thank you. I can see the restlessness in the audience. Anyway, this is the last session, and please hold yourself for a few minutes to listen to the most dynamic, the most vibrant person, and the brainchild and the organizer of this Speracon, a wonderful conference, a physical conference after a long, long time. Oh, thank you, Vidvi sir. I was left alone. My co-chairpersons have already left for some important commitments. Now, today Rajesh is going to talk on the wows and the oops movements in laparoscopy, and who else can be the most dynamic, the most wonderful person, and a very eminent figure in the field of endoscopy. his biodata is so exhaustive that it is really impossible to do justice to his accomplishment in any way. So I'm just going to cut short and say only 2 lines about him. He, as I already said, he's the organizer of this today's conference. He's so passionate about laparoscopy that he has innovated the wonderful concept of day care hysteroscopy, and we have ourselves witnessed how wonderful the patients recover. And he has been conducting, he's so generous, he's so kind, that he is being conducting ongoing workshops, training workshop for the juniors, for the learners who want to excel in laparoscopy, and he conducts them in Akola and all over India ongoingly every year. But this COVID has, really changed the scenario. For the last 2 years, we have been longing to see all these things. He is also a very active member of FOXY, and he has held very important posts, like he was chairman of the endoscopic committee long back, and also the vice president of FOXY. And we look forward, Dr. Rajesh, we look forward to see you as a president of FOXY.
Hopefully not.
With these few words, I invite Dr. Modi for his wonderful talk.
Thank you, Dr. Devre and sir. We are already running a bit late, so I'm going to be a little brief in the videos. Volume kam karo, ekdam low. So my pet surgery is about hysterectomy and daycare hysterectomy. So that is something which I really feel is one of the wow moments every time I operate. The crux is to be able to have a bloodless surgery, to be dissect the tissues and have them respond to your touch. So that is what really makes the effort worthwhile. That when I'm trying to dissect, when I'm trying to skeletonize a uterine, after some cases, after some 20, 30 surgeries, you start understanding the tissues properly. You start realizing that, okay, this is how you get the correct place and this is how you can manipulate and handle the vessels, avoid the ureter, avoid the bladder, and still achieve a clear skeletonization of the uterine and have a bloodless hysterectomy. So when you are able to do that, that is when you really feel that there is a lot of satisfaction in the surgical output. You should not be struggling to finish a hysterectomy. It should be a pleasure to operate. You should enjoy the drive. You should enjoy the surgery. And at the end of it, you should feel satisfied and thrilled. This is just a video to show that this is how we identify the ureter. There are some technological advances which help. And then you dissect. Some steps, once you understand them, they become a reflex action. So here we have the ureter being isolated and identified with the catheter. I don't need the catheter nowadays. We don't use it for every patient. But once you have the understanding of the tissues, once you are confident of your surgical dissection, and you really see the tissues responding to your touch, that is when you really feel that this is, wow, this is a nice surgery. Here you can see the water flowing under the bridge, the transverse part of the uterine sitting on the ureter. The amount of traction is one simple thing which helps me to prevent injuries. So now you can see that the transverse part is sitting on the ureter, and then if I am giving traction on the uterus, that entire part gets lifted away. The ureter stays lateral, only the uterine is lifted away, so the chances of injuring or damaging the ureter as well as the bladder is not very high. Once you understand these concepts, once you understand these principles, things really become easy. And then you improvise on the outcome. So this is our daycare surgery. Long time back. This is from 2007. So almost since 2004, 2005, I have been doing the daycare surgery. So this is at 5 p.m. in the evening on the same day of surgery. So patients come in the morning, they get operated, they get up and walk around after 2 hours, and in the evening they go home. This particular patient is from the workshop which I did in Nagpur. Hysterectomy done in the workshop in the morning, and in the evening she is in the auditorium talking to the audience. There are some situations where you initially feel that this is, oops, this is too much of an adhesion, and you're not sure whether you'll be able to manage this case. Frozen pelvis is something which we get very often. So you lift the uterus, and the entire pelvis is getting lifted up. There are certain surgical principles here which help you to get the desired outcome. And then when you are able to get the exact same desired outcome which you do in routine cases, that is what again you convert your oops movements into wow. For all these cases, what we do is we use vasopressin. I am filling the uterus with saline with vasopressin, and because we are filling the uterus with saline and vasopressin, the blood in the uterus is replaced with saline. So when I dissect, I do not use energy source, I do not use cautery. There is no bleeding backflow from the uterus. So any bleeding, any backflow which comes is coming from the bowel side. So that gives me an indication that I am now going towards the bowel. I need to go flush to the uterus. So very simple concept, but it allows me to avoid using cautery. If I have not used cautery and if my surgical field is clear, I am able to get a fantastic result at the end of the surgery. I hope the picture is clear. Thoda lights dim karna hai. 400 units, 400 ml of normal saline with 40 units of vasopressin and only scissors. There is always a plane available. However bad the is adherent, it's a bowel. So food is passing through the bowel. When the food is passing through the bowel, there is peristalsis, there is movement. It ends up creating a plane between the bowel and the uterus. You need to be able to see the correct plane and you need to be able to stay in the correct plane. So here you can see there is no bleeding from the uterus. If there is bleeding, I know that I am going close to the bowel, so I stick flush to the uterus. So now when I am separating, because there is no bleeding, the field is also clear, I can visualize the plane very well, and the dissection goes continuously and smoothly. So this is something which it probably would not be very routine to do if you are in your learning curve or in the beginning of your 100 cases. I usually say that it takes 100 surgeries to become very good at it. So if you are beginning to do a laparoscopic hysterectomy, you need to be able to do 100 laparoscopic hysterectomies before you enter into such kind of cases laparoscopically. I guess probably the case would be difficult even for open, but the surgical principles remain the same. Being flush to the uterus, have a clear field. I don't like to keep on giving a wash during the surgery because it unnecessarily wastes time. The effect of vasopressin will wear off faster and then it will end up making more of a mess for me to progress. So this is something which comes out of experience. There is no substitute to the number of years that you put in and the number of surgeries that you have to put in to be able to become good in whatever you are doing. Operate, operate, operate. That is the key word. Get as many surgeries as possible. Finish off your learning curve, finish off your 100 hysterectomies, and you are really good enough to become an expert in laparoscopic hysterectomy. It's not very difficult. It's not something which cannot be attained. But you need to have the confidence that you are going to reach that place. So here you can see that almost it is completed. There are some oops moments which do come up, even today. Now this is a comparatively recent surgery which I am doing. Patient is previous 3 cesarean sections. So I know that bladder is adherent. I know that the bladder is going to be plastered. I have the latest. This is a 3D system from Olympus and Thunderbeat. There is nothing better than Thunderbeat as of today. And still, here you can see that I am going flush to the cervix as far as possible and the bladder opens. So it's something which is part of surgery. Now, if it is a patient with previous cesarean and I have opened the bladder, now it doesn't feel like an oops. Now it feels like, wow, I have got a recording. So from that context, it is an experience. I have opened bladders, I have sutured bladders, they have healed properly, and I am confident that when I close the bladder, she's not going to have any further problem. Sometimes patients will come with previous multiple cesareans, and they will ask me, urine leak hoti hai kya baad mein? That means she has already been counseled. If you undergo laparoscopic hysterectomy, you will have urine leaking later on. So I have to tell my patients that the bladder is adherent, bowel may be adherent, we operate. There might be a possibility that I might have to operate on the bladder because if it is too badly stuck, I have to separate, to repair it. It's part of surgery. There is no problem. Eventually, you will heal within 8-10 days, definitely. So the moment I tell them that everything is a part of surgery, my patients are confident they get operated with me. Here you can see, now this is an oops moment which ideally should not happen. Bowel is stuck and I did not notice, and we used the thunderbeat a little close to the bowel. Fortunately for me, in this patient, nothing went wrong. But these kind of oops moments are something which should not happen, that you have accidentally cauterized a bowel and you have not noticed it, or you have not repaired it adequately. Anything which goes wrong or which is not expected happening on the table is fine as long as you detect it and you repair it on the table. It should not happen that I have cauterized close to the bowel, I have failed to notice it, and then later the patient comes with a peritoneal fistula or peritonitis. So that is something which definitely has to be prevented and avoided. Like I said, in this particular patient, I did go a little close, but it appeared to be just a superficial serosal injury. So with experience, you can deduce that I don't need to now take a suture to bury that area. And this, I have left it as it is. She did not have any problem. There are times when I have put the trocar in the bowel, something like this. A patient of primary infertility, no previous surgery. I've put the 10 mm trocar and you can see bubbles. Bubbles are not good. Bubbles means you are inside the bowel lumen, and this is intraluminal. So we are withdrawing the scope, identifying the plane, getting into the peritoneal cavity. So this is an oops moment which is going to happen if you have not had a bowel entry, you have not done enough laparoscopies. So it is something which has to happen sometime or the other. Wait for it, deal with it, and overcome it. Now here in this particular case, like I said, that we are now withdrawing the trocar slowly to see if I can find the plane. And right in the midline, right from the xiphisternum to the pubic symphysis, there is a bowel loop adherent. The bloated bowel loop is a good sign. That means there is only an entry wound. There is no through and through. There is no exit wound. So I have done adhesiolysis, and now I know that it is only a entry wound which I have to close. I don't have to worry about missing out on an exit wound. So that is the reason why I said that the bloated bowel was a good sign that the bowel is not having any other leak. So this is a bowel repaired. The same thing can happen in bladder. There is a possibility that you may have an ischemic injury which comes up with a fistula later. Here what I usually recommend, you should be able to review your video and figure out where you have cauterized close to the bladder so that you can learn from your mistake and prevent those issues from happening again later on. This is all part of the learning curve. This is all part of the experience which you need to gain. And as I mentioned earlier, this is the experience which will come only if you have done enough surgeries and over a number of years. I think I would like to stop over here if you are fine with it. There are some other bleeders which I have to show. Bleeding is something which is part of a surgery. We now don't really consider bleeders as a problem or a complication. For any bleeding, the backup or the thought in the mind is I can always open up, I can always control the bleeding, and it can be managed easily. Converting to a laparotomy is not an oops moment. Converting to a laparotomy is a part of laparoscopic surgery. And we always have that preparation done. For a patient like the frozen pelvis, we always tell the patient, if it is possible to do laparoscopically, we will do it laparoscopically. If at any stage I find that by opening up and putting my hand inside, I will be able to dissect better, I will open up. Patients will never object. Patient has no particular predisposition ki laparoscopy se hi karna hai. Patient is worried that the uterus has to come out and she has to heal. So it works the same for myomectomies. Multiple large fibroids, myomectomies, patients come. Even today, I tell the patient that if possible, we do it laparoscopically, otherwise we can always open up. The end result is the patients want the fibroids to be removed and the fertility to be preserved. Thank you. Thank you all for the patient hearing. Thank you very much for waiting till so late, being a part of the program. And thank you to the chairpersons also.
Rajesh, very nice. I know there are no oops for you now. It's always It's always for the beginner, and with so much experience all around throughout the year and so many years, now no oops for you, right? And
Very true, very
I
true.
always love your surgery, and I know it's very neat, clean, and bloodless. That's what I appreciated very much.
Thank you very much.
Thank you, Rajesh.
I would like to take this opportunity to thank Indoco Remedies for being our sponsor and for supporting the whole program. Pushan, please come up. I would like to again thank you all also and the chairpersons, and Pushan will address us, and then kindly all please join us for lunch.
First of all, from behalf of Indoco Remedies Spera Division, I heartfully thanks to all the doctors who are present here and around 500 doctors who have attended online, all India. So it was a very gracious presence, and your presence has only made this program wow. It would have gone either way, oops or wow. Thank you for making it wow. My heartfelt thanks goes to everyone, all panelists, MOCs, moderators, speakers, and especially Dr. Rajesh Modi, who has laid down the total blueprint of scientific program with Dr. Anuradha Ridhorkar. Thank you to Madam also, and made it so success. I'm also thankful to Nagpur Obs and Gynae Society, President Dr. Alka Mukherjee, Dr. Ujjwala Deshmukh, President of NARSI, and all other gynae doctors and associations in and around Nagpur. We are also thankful to AEM, our event manager, for managing the event so beautifully, and to Radisson Blue. And with that, I would also like to take the opportunity to thank and appreciate the effort taken by my field people, my colleagues. I'd like to introduce with you all our colleagues, Mr. Shubham. Shubham, can you please show your hand? Yeah, well done, Shubham. Mr. Atul, please come here, please, everybody. Okay, yeah. So, Atul and Rajkumar. Rajkumar, can you please wave your hand? Yes. So, they got a good guidance by our area manager, Mr. Shyam Kale, and Mr. Sushant Deshmukh, who is the divisional business manager of Nagpur, and our West Zone manager, Mr. Ritesh. And from our head office, myself, Pushan Acharji, I also had Mr. Samir, who is GM from Corporate Relations, Mr. Amit Bhatt, he is AGM, and Komal Rangankar, Group Product Manager. So from all of us, thank you and a great salute to you all for making this moment a big, big wow. Thank you so much.
Thank you, Dr. Rajesh and Indoco Spera Division for giving us this opportunity to share a very important session. Thank you.
I request all the doctors to please join us for lunch. Thank you.
Recording stopped.
Hello.